Good morning, everyone. How's everyone doing? I guess it's been 2 years since we've been in person, so I guess that's a positive thing that maybe COVID is on the recess for a while or perhaps downtrending. It's great to have everybody here. We're going to start out with the chief residents. I'll introduce them and then we'll have a little discussion after each talk. We're privileged to have Dr. Andersen here as our visiting professor. While he's a foot and ankle surgeon, he knows something about everything, including your talks. So all questions are fair game, I guess. And with that, we'll start with Dr. Bailey. Zach, you all. Zach's a Nebraska guy. He is off to Harborview to do a spine fellowship next year. We're excited to hear him talk about some of the things they've done with spine surgery with pain management. Zach, thanks.
Oh gosh. Oh gosh. What's happening? Get it out of here. Thanks for the introduction. I'm Zach Bailey. For those of you that don't know me, I'll be talking about opioid prescribing habits after single level posterior lumbar spine surgery. Here are disclosures. We have nothing to disclose. So some background. So as we all know, postoperative pain control is important, but there has been a growing epidemic of prescription painkiller abuse. And this all kind of started back in the 90s. In 1996, the American Pain Society coined pain as the fifth vital sign, and we've been kind of dealing with the aftermath ever since. So now Americans consume about 90% of the world's global opioid supply, while representing only 5% of the world's population. And drug overdoses, now the leading cause of accidental death, with opioids being the most common offender. Of prescribers, surgeons are the second highest prescribers of opioid pain medications, secondary to only chronic pain specialists. And it's thought that orthopedic procedures result in more pain due to manipulation of musculoskeletal tissue, which is highly innervated. And of orthopedic procedures, spine surgery is often regarded as one of the most painful orthopedic procedures. As many as about a quarter to more than half of patients undergoing spine surgery are using opioids preoperatively, and patients undergoing elective spine surgery are at risk for increased opioid abuse or dependence after surgery. There is substantial variation in prescribing, however, and it's estimated in one study that up to 70 to 80% of opioids being prescribed are not actually used after surgery. And so there's been a lot of research looking into this and trying to figure out ways that we can prescribe patients kind of a more accurate amount of pills so that they're just using what they need. You're not overprescribing. Stanek et al. Did show that there was a significant decrease in opioid prescribing in hand surgery after a protocol was implemented, which is partly the basis for this study. And another study found that the mean number of opioid pills being prescribed in lumbar decompression with or without fusion was approximately 107, with a fairly wide range, as you can see here. And currently there's no comprehensive guide or protocol to inform surgeons on how many pills to prescribe after common spine procedures. So the purpose of this study was to determine the quantity of opioid pain pills being prescribed, factors associated with increased opioid use, and the optimal amount needed to treat postoperative pain after single level posterior lumbar spine surgery to ultimately improve opioid prescribing practices. Our material methods. So this was a retrospective chart review. We looked at patients undergoing single level posterior lumbar spine surgery from 2018 to 2019. We separated them into two groups, those undergoing decompression, which includes things like laminectomy, discectomy, microdiscectomy, hemilaminectomy, or intramitted fusion, including TLIF and posterior lateral fusion. Patients were excluded if the surgery was indicated for trauma, tumor, or infection, or if they were minors under 18. So the primary outcome measure was the number of 5 milligram oxycodone equivalents being prescribed, initially post-op and then total, including refills. And then some of the other measures we looked at include things like age, sex, BMI, ASA score, hospital length of stay, opioid use within 30 days after surgery or more than 90 days. Within 30 days before surgery or more than 90 days after surgery, the number of refills, quantity of pills refilled, and then pain scores. So this is kind of a big table summarizing most of our results. As you can see that there was significant differences between the two groups in regards to age, sex, ASA score, and length of stay, with the fusion group tending to be older, more likely female, higher ASA scores, and longer lengths of stay. There was no difference between the pain scores between the two groups. Actually more than a third of patients undergoing either decompression or fusion were using opioids preoperatively. And there was a difference between the number of pills prescribed for each group. So you can see that the median number of pills prescribed for the decompression group was about 30, whereas the fusion group was about 50. Patients undergoing fusion required more refills than patients undergoing decompression alone. And then you can see when you account for refills, the total number prescribed for the decompression group was the median was about 40, and the median for the fusion group was about 60. So this is just a graph kind of depicting some of that. This is the quantity of pills prescribed for each group at discharge, refills, and total. And you can see that the red group, the red bar is the fusion group, and that they were prescribed significantly more than patients just undergoing decompression alone. This is some of our correlation data looking at correlation between quantity of pills prescribed at discharge or refills and various factors. And so there was a small but significant positive correlation between ASA score, pain scores, preoperative opioid use, and length of stay in regards to the quantity of pills prescribed. And this is a box chart looking at the quantity of pills prescribed as it relates to preoperative opioid use. And so patients that were using opioids preoperatively were prescribed significantly more opioid pills at discharge in total. And this is looking at the quantity of pills. This is a scatter plot looking at the quantity of pills refilled and the quantity of pills prescribed at discharge. And again, there's a small but significant positive correlation between the amount of pills you prescribe somebody at discharge and the amount of pills that they're going to refill, which I think is interesting. So that basically is in our control. The more pills you prescribe somebody at discharge, the more likely they're going to end up needing a refill. So I think that's an area that we can intervene on. So some limitations of this study is that this is a retrospective study. There's no data that we have regarding how many pills were actually taken or how many were unused. We had kind of some incomplete data on that, and unfortunately weren't able to draw any conclusions from any of it. Pain medications from other sources are not able to be accounted for, so we can only account for what was documented in our system. There's various comorbidities that can contribute to increased opioid use, and they may confound the results. So in summary, more than a third of patients were using opioids preoperatively. Patients undergoing single level posterior lumbar decompression required fewer opioid pills than patients undergoing fusion alone. Preoperative opioid use, higher pain scores, longer length of stay, higher ASA score were all associated with increased postoperative opioid use. And the quantity of pills prescribed at discharge does positively correlate with the quantity of pills being refilled. So in conclusion, or the conclusions that I kind of drew from this study were that by prescribing amount at or slightly below the median value determined in the study, we can meet the pain demands for most patients while reducing overprescribing habits. So I would suggest an initial prescription of 20 to 30 pills of 5 milligram oxycodone equivalents for single level posterior lumbar decompression, and about 40 to 50 pills for single level posterior lumbar fusion, with no prescriptions given beyond 90 days. Here are my references. I'll take any questions.
We started looking at numbers, and we went to a 40 pill prescription, and now you have to come in to get a refill, and it has to be picked up by hand. We're finding very few people are doing that. And these are some pretty large, complex foot and ankle cases with multi-level fusions and big realignments. So, we're doing a lot of more multi-modality treatments. So everybody gets an anti-inflammatory now, which we didn't do before. We were worried about the healing effect. We do complementary medications. So we use Flexeril and Celebrex and Tylenol and Tramadol, and we have them stagger it. But our goal is to try and get everybody off narcotics within 7 days.
Okay, Zach,
Thank you.
Well done.
Thanks.
We're going alphabetically. Next up is Dr. David Brown. David came to us from Texas. He's a UT graduate, UTMB medical school, and then here for orthopedics. He's doing a sports fellowship back down in Baylor in Houston. And then I think he's pretty close to has a contract down there. So looking forward to your presentation this morning, David.
All right, we'll get going here. My name's Dave Brown. I'm one of the 5th years here. I'm going to be doing my talk on the effects of malnutrition on perioperative complications in patients undergoing rotator cuff repair. Disclosures. Authors, Dr. Tusing, as well as myself. So as far as a little bit of background, there's been a tremendous amount of literature published on the effects of malnutrition in orthopedics, leading to inferior outcomes, increased wound healing issues, as well as infection. Primarily, the research you'll find out there is in the arthroplasty world, the spine world, as well as like hip fractures. Even in our time, I feel like there's been a ton of literature over the course of the last 5 years on these topics. You don't see a lot in the sports world on this, though. So again, it's just kind of sparse out there. So albumin has been recognized as one of the overall markers of, or one of the markers of overall nutritional status and wound healing capacity. There's others as well that people use: prealbumin, transferrin, retinol binding protein. But the one that you see in the orthopedic literature most common is albumin. So the purpose of our study is to determine whether malnutrition as defined by an albumin less than 3.5 grams per deciliter placed patients that have undergone arthroscopic rotator cuff repair at a higher risk of medical perioperative complications, mainly infection, stroke, MI, pneumonia, pulmonary embolism, DVTs, renal complications, blood loss, as well as UTI. And as a secondary purpose, it was to assess the impact of malnutrition on some other operative metrics such as length of surgery, length of stay, readmission, reoperations. Pretty straightforward study. With the COVID coming up, I was looking for a study that I could do that wouldn't have to have access to patients or clinical setting, and so NISQIP kind of lended itself nicely to this time period. So this was done through the American College of Surgeons National Surgical Quality Improvement Program database to identify patients that had undergone rotator cuff repair. The data sets we used were 2012 through 2017. In some ways, it was kind of forced our hand. If back before 2012, they were obtaining different data sets, and that particular range allowed us to kind of have comparable data from the different years. Unfortunately, one of the limitations is that it only provides data that extends out 30 days from that operative period. We identified patients who were malnourished as defined by an albumin less than 3.5 grams per deciliter and compared their data, their labs, their comorbidities, perioperative complications against those that were not malnourished. The sample size was reasonable, 7,688 patients. The malnourished group had 278. The non-malnourished group had 7,410. Again, data to be collected, demographic characteristics, some clinical characteristics, whether they're diabetic, smokers, COPD, CHF, hypertension, they are undergoing dialysis, weight loss, ASA class, as well as operative time. And then again, looking at those perioperative complications as listed. So again, we use that NISQIP database set. Basically, we're able to, I don't know if any of you guys, I'm sure several of y'all have used this set, but you essentially have to put in specific search criteria. So we use CPT code 29827, which is the arthroscopic rotator cuff repair CPT code. And then we're able to group them into malnourished, not malnourished, and compare those different data points and run statistical analysis on them. As far as results, it was honestly surprising to me, given what we see in other orthopedic fields, but there was no superficial surgical site infections in the malnourished group, no deep infections. Really, there were no statistically significant findings in the malnourished group. There was a trend towards some increased pulmonary complications, but again, not statistically significant. There were some findings with regard to length of hospital stay. Again, this is just kind of a graphic representation of the same. And then again, when looking at some of those other metrics, for instance, operative time, length of stay, reoperation rate, as well as readmission. Patients with a low pre-op albumin had significantly longer mean hospital stays, as well as increased readmission rates as well. So conclusions that we drew, while there does seem to be an association of malnutrition and perioperative complications in other types of surgery, this doesn't appear to be the case with regard to arthroscopic rotator cuff repair. And patients with malnutrition were found to have significantly longer mean hospital stay, as well as increased readmission rates. Again, there are some limitations of this study. Like I mentioned, we're only able to look at 30 days out from surgery. So I'm sure that you may pick up a few other complications further out. We were also limited in our time frame because those databases changed. But if anything, I thought that this probably catches the worst of the patients, because up until the last couple of years, albumins were not commonly obtained on all of our preoperative patients. Now it's still not obtained on everyone, but it's probably more your high risk patients that they're obtained on. But if anything, this would kind of lean towards overrepresentation of the unhealthy patients, I would believe. So I expected we were going to find higher infection rates, but wasn't what we found.
David, what are your thoughts about why it didn't pick up higher infection risk?
I think it's a good question. I think that, this is all database driven. You have to report it into the database for us to collect the data. And I think there's some flaw there. Anytime you're trying to rely on the database to pick these up, I don't know if there's accurate reporting in every instance. It's hard to say.
Do you think the comorbidities played a role?
Sure, but like I said, I think that probably those folks who were had the higher comorbidities, the higher risk profiles, were probably the ones who were included in the study, because they probably the ones who got the albumin.
What I'm saying is, do you think maybe the comorbidities were more dominant as a risk factor for infection than albumin?
It's definitely possible. Yeah.
What are your thoughts when you go forward and you're down in Baylor or wherever you're going to assess your patient's nutrition for that?
Yeah, I still think regardless of this data, you always want to try to set yourself up for success, set yourself up and your patients up. And if they have a low pre-albumin, I still think it's important to optimize them from a nutritional standpoint. But I don't think in the sports world it's as big of a problem. But for you guys, I think it's really important.
Did you stratify why they got readmitted? Was it? They didn't have wound problems. Was it cardiac related?
No, I didn't stratify that.
Dr. Tusik, any comments, thoughts? Probably.
This is, yes, you hit on it. This is a data set. These are not normal people. No normal people get albumins drawn for an arthroscopic coverage. They're already have major comorbidities, because I draw zero albumins, have zero intent of ever drawing an albumin on a normal 50-year-old that I'm fixing their cup. The reason infection can't be pulled out is because it's exceedingly rare. I've had 1 in 9 years after a cup repair. So your N on this is exceedingly rare, because you're making 5 poke holes around their shoulder and pumping 15 liters of fluid through their shoulder doing the scope. So infections are exceedingly rare. And then lastly, this is a 30-day data set, which most of your infections, if there is going to be one, is going to be C. acnes after an arthroscopic cup repair, which is probably going to show up after the 30-day mark. It's going to be between 4 and 6 weeks and not be caught in this data. So a lot of reasons. It's an interesting topic, I think more relevant to joints and fracture work, not really that applicable to sports world.
That's good. Any other thoughts, questions? You're gonna let David off the hook? All right, good job. Thank you. Next up, Dr. Heiden. Jace is also a Nebraska Wesleyan Med School here and residency. He's off to Wisconsin next year to do a sports fellowship, but today he's going to talk about hip fractures and early mobilization. Jace?
Well, good morning. Like Dr. Garvin said, I'm Jace Heiden. For those I haven't met, I'll be presenting my research on early ambulation after hip fracture surgery and its association with decreased 30-day mortality. Authors of our study include myself, Dr. Stephen Gooden, who is also a medical student here and is now a resident in Michigan at Grand Rapids. Doctors Mormino, Siebler, Putnam, and Tao, and our statistician, Liz Leiden. And disclosures for our authors are as listed here. So first, some background on hip fractures. They're associated with significant morbidity and mortality with an annual incidence nearing 1.7 million patients. Up to 25 to 30% of these will be deceased by 1 year after their injury. And mortality is 3 to 4 times higher compared to age matched controls in the general population. And about half or more of these never regain their prior level of function. And to put this into scale, an estimated $9 billion is spent annually in our country alone for the management of these injuries. So literature has shown that expedited fixation after hip fracture leads to fewer complications and increased survival, with early postoperative activity leading to improved mortality rates. In long term, the inability to stand, independently sit down, and perform ambulation have proven to be harbingers of mortality. However, to date, there's been a paucity of data in the literature on progression of ambulation in the immediate postoperative period and its effect on ultimate outcomes, with no evidence of quantitative distance walked in relation to mortality. So with that in mind, the purpose of our study was to evaluate 30-day and 1-year mortality following hip fracture surgery in relation to the level of mobility achieved on the first 3 postoperative days. We also looked to stratify mortality based on the distance walked and quantify the importance of early ambulation. And finally, detect any relationships between observed mortality, the comorbidity burden, and the time elapsed from the injury to surgery. So inclusion criteria for our study included a study period from 2012 to 2018. Patients being 65 or greater, having sustained a low energy mechanism of injury that resulted in a fracture pattern of a femoral neck, intertroch, or subtrochanteric femur fracture. Surgical treatments under the umbrella of our study included closed reduction, percutaneous pinning, sliding hip screw, cephalomedullary nail, and then arthroplasty with hemiarthroplasty and total hip arthroplasty. For our data collection methods, we looked at inpatient postoperative physical therapy notes and reviewed these, looking for the distance walked in each of the first 3 postoperative days. Also at the level of assist and if a walking aid was required. We looked at the admission status and the time elapsed from when they presented up to the point of the incision and surgery. We looked at a modified 5-factor index score and tabulated this for each patient. And finally, the mortality status at both the 30-day and 1-year mark from the date of surgery. Briefly, this modified 5-factor index score includes these factors of diabetes, hypertension, congestive heart failure, COPD, and whether or not they have independent functional status. It's a concise barometer of patient frailty, and it's recently demonstrated utility in both the arthroplasty and trauma literature to identify high-risk patients and to guide their care. So to our database, we had a total of 485 patients who met inclusion criteria. 218 of these had appropriate documentation of their ambulation and gait data, and 157 were reported to have walked a measurable distance in the first 3 days. This graphic shows our mortality results with on the y-axis the mortality rate in percentage, and then on the x-axis the left couplet shows results at 30 days, with those being able to walk in the first 3 days having 3% deceased compared to a larger 13% who were unable to ambulate in that period. And then towards the right couplet, looking out to 1 year, we found that 15% who were able to walk in the initial period were deceased compared to the larger 28% who were unable to ambulate from those first 3 days after their surgery. This table shows the effect of our patient ambulation on mortality without looking at the comorbidity burden of our cohort. We found at 30 days that there was an over 4-fold correlation with the ambulation coefficient if patients were able to ambulate in those first 3 days on their mortality at the 30-day mark. And then further out at 1 year, we found that there was an over twofold odds ratio with 2.26 for mortality based on those first 3 days after their surgery. We did also look at the patient status, whether they were an initial internal presentation to our facility or if they were transferred from another facility, trying to detect if any delay towards the time of their surgery had an impact on their ultimate mortality. We looked at statistics in both at 30 days and 1 year and found that this admission status was not found to be significantly associated. Further statistics with regression analysis found that after further analysis with their comorbidities included, we found that there was still a 4-fold increase in difference based on the ability to ambulate in those first 3 days upon 30-day mortality. Further out to 1 year mortality, we found that there was an insignificant difference with the 1.66 odds ratio, an insignificant p-value based on the first 3 days of ambulation. Towards that middle column with age, we also looked at the ages of our cohort and found that with the odds ratio of 1.05, that this signified that there was a 5% increase in mortality based on each additional year of the patients. And then finally in that row with our modified 5-factor index score, we found that for each unit of increment from these 5 factors, there was a 62% increase in mortality at 1 year. Both of these last two were not significant at 30 days. So we do recognize several limitations of our study, being reliant upon physical therapy documentation, and with that, a lack of standardized data entry, and of course, the retrospective nature of my study. So in conclusion, we found that ambulating in the immediate postoperative period was associated with an almost 4-fold decrease in 30-day mortality, but that it was not associated with 1 year mortality. We found that the risk of 1 year mortality increased 5% with each additional year of age in our cohort, and that the mortality risk increased 62% for each additional modified 5-factor variable present at the time of their injury. Study was published last year in the Yellow Journal of AAOS, as well as presented as a podium presentation at MAOA last fall. So thank you for your time and attention.
Questions?
So how does this change your practice? Do we push cardiology to clear these patients on the day they come in so that we can get them to the OR that day or the next day?
Yeah, I think that's definitely a contentious subject here with cardiology clearance. We found ultimately here a lot of times with the cardiology delays, it doesn't really change the ultimate outcome or that we're going to treat them with surgery. So, we've tried to be a little more outspoken and get these folks to surgery quicker. I think it certainly shapes the framework when we visit with these patients and their families to kind of let them know the impact that hip fracture does have upon these patients and their ultimate outcomes.
And do you think the cause and effect was how quickly they got surgery that led to how quick they got out of bed, or were the older, more disabled people just less likely to get out of bed post-op day 1?
I think the latter. I think their comorbidity burden and their ultimate physiological reserve probably plays a greater impact in that.
Follow-up question there, Jace. One of the reasons to do total hip arthroplasty in this patient, in this population, more than used to, is for early ambulation. Were you able to look at that as a risk factor, whether they had a total hip endo or fracture fixation?
We looked at those together. I don't think we found any significant difference versus the nail fixation versus hip arthroplasty. We tried to tease those out based on their surgery and didn't find any significant difference in this cohort.
Probably would take a fair number of patients to sort it out.
Yeah, to have enough power.
Yeah, Kevin, I was just commenting on that. We wanted to look at that.
Right. Thank you.
Move on to Dr. Roedel's. Gordon's came to us from Wartburg undergraduate, University of Wisconsin, residency here. He'll be off next year to do an arthroplasty fellowship at West Virginia. Today he's going to speak to us about total hip arthroplasty in those patients who are 50 and younger. Gordon, please.
My name is Gordon Roedel, and on behalf of my co-authors, Dr. Kildow, Dr. Sam, and Dr. Garvin, I will be presenting our findings on total hip arthroplasty using highly cross-linked polyethylene for a patient population 50 years and younger with a minimum 15-year follow-up. These are our disclosures. The success of total hip arthroplasty in effectively improving pain and dysfunction among patients who are elderly with end-stage osteoarthritis has broadened its indications. And as a result, we've seen a trend over time in which younger patients are undergoing total hip arthroplasty. And compared to this older population of patients, this younger population desires a return to higher levels of activity and requires longer implant survivorship. Historically, the barrier to implant survivorship in young adults was polyethylene wear, with the subsequent particulate debris activating the osteoclastogenic pathway, resulting in ultimately bone resorption, periprosthetic osteolysis, and eventual aseptic loosening. Several investigations looking at 10-year midterm follow-up of total hip arthroplasty with conventional polyethylene demonstrate osteolysis rates up to 56% with 10-year survival rate of these implants as low as 83%. The introduction of highly cross-linked polyethylene has greatly improved the durability of total hip arthroplasty. Midterm follow-up has demonstrated low rates of wear, osteolysis, and implant loosening. A previous investigation of patients aged 50 years or younger undergoing total hip arthroplasty with highly cross-linked polyethylene performed at this institution found low rates of linear and volumetric wear at 9-year follow-up without evidence of loosening or osteolysis. Recent randomized controlled trials have demonstrated excellent wear rates and implant survival out to 15 years in young patients, while others have found similar results beyond 15 years in an older patient population. However, there were no studies that were looking at a minimum 15-year follow-up of patients aged 50 or younger at the time of surgery. Therefore, the purpose of this study was to investigate the results of total hip arthroplasty using highly cross-linked polyethylene in patients aged 50 years or younger at the time of surgery with a minimum 15-year follow-up. To accomplish this, we set the following clinical, radiological, and wear-related outcomes as our primary and secondary outcomes. We retrospectively reviewed prospectively collected records of a consecutive series of patients who underwent total hip arthroplasty at an age younger than 50 between November 1999 and April 2005. During that time frame, there were 105 total hip arthroplasties performed in 95 patients who fit this description. Of those patients, 8 hips and 7 patients were lost to follow-up, and 1 hip underwent a revision due to subluxation secondary to small femoral head size prior to reaching that 15-year follow-up. So this left us with 96 hips and 87 patients with a minimum 15-year follow-up for inclusion, with a mean follow-up of 17.3 years and a mean age at the time of surgery of 41.6 years. And these patients either returned for follow-up evaluation or completed a questionnaire if there were clinical data that were incomplete. Of this group, 77 hips among 67 patients had radiographic follow-up, and 72 of those hips had sufficient quality of their radiographs to perform polyethylene wear analysis. All of the total hips were done through a posterior approach. The acetabulum was reconstructed utilizing a press fit trilogy cup, and the longevity highly cross-linked polyethylene liner was used in all patients. On the femoral side, 95 of the patients had a press fit tapered titanium synergy stem, with 1 patient that had a porous coated non-modular prodigy femoral stem. And the femoral head material was chosen based on surgeon preference, which changed over time. And that consisted of 19 cobalt chromium, 34 ceramic, and 43 oxidized zirconium heads. And the bearing diameter of these heads was either 26, 28, or 32 millimeters. Clinical outcomes were measured with the Harris Hip Score, which was collected preoperatively and again at postoperative follow-up. Each patient's medical record was also reviewed for complications that took place from the time of surgery until most recent follow-up. Radiographs from the first postoperative image to the most recent follow-up were systematically reviewed and analyzed for the presence and progression of radiolucent lines, osteolysis, or change in implant component position over time. And you can see the definitions of each of those listed there. We also, when looking for the evidence of radiolucent lines or osteolysis, assign those to the acetabular zones designated by Dilly and Charnley, or the femoral zones described by Gruen. And then polyethylene wear was measured using Polyware version 8. And this is a validated software that uses AP and lateral radiographs of the hip to provide outcomes on linear and volumetric wear. And so these images, we use the images from 1 year post-op to allow for a bedding in period, and then compared those to their most recent images. And our statistical analysis, we used one-way analysis of variance to compare the 3 femoral head sizes as well as the 3 femoral head materials, and a paired t-test was used to compare the preoperative and postoperative Harris hip scores. As far as our clinical outcomes, we found that the Harris hip score significantly increased from a mean preoperative score of 52.8 to postoperative 94.8, with a mean improvement among all patients of 42.4. And we found that all patients had an improvement from their preoperative to their postoperative score. As far as complications went, there was 1 deep vein thrombosis found, and as previously mentioned, 1 patient who had undergone revision due to recurrent stability, and that was related to a small femoral head size. However, we did not find any patients that underwent revision due to mechanical loosening or osteolysis. Radiologic analysis found radiolucent lines present in Delian-Charnley zone 1 in 23 patients, zone 2 in 6 patients, and zone 3 in 7 patients. Our previous head report had found 9 hips with radiolucent lines seen about the acetabular components, and comparison of the individuals identified in that previous study to this longer term follow-up found no progression in their radiolucent lines. Of the hips with new radiolucent lines, 14 were found in zone 1. And then looking on the femoral side, there were 2 patients who had radiolucent lines and grew in zone 1 and 7. And these were unchanged from the previous analysis. Those are the same patients with osteolysis in the same, or radiolucent lines in the same areas. We did not find osteolysis present in the hips of any of our patients, and no change in component position, subsidence, or loosening. A total of 72 hips had radiographs of sufficient quality to perform the polyethylene wear analysis. We found a mean linear wear rate of 0.04 millimeters per year and a mean volumetric wear rate of 6.22 millimeters cubed per year. And comparison of the wear rates by femoral head material did not reveal any significant difference between femoral head size or femoral head bearing surface. So to summarize what these results signify, this investigation represents the longest clinical follow-up of patients under the age of 50 with total hip arthroplasty using highly cross-linked polyethylene. We found a very low rate of complications with no revisions for osteolysis or mechanical loosening, and satisfactory clinical outcomes with 96% of patients reporting good or excellent outcomes using the Harris hip score. We found a very low rate of linear and volumetric polyethylene wear, which was consistent with midterm wear rates and greatly improved over the long-term wear rates seen with conventional polyethylene. We also did not find evidence of osteolysis. However, we did note radiolucent lines in a large proportion of patients, including nearly 30% of patients with radiolucent lines in zone 1. However, longitudinal assessment of these radiolucent lines found them not to be progressive over time, and all lines were less than 2 millimeters in thickness. So given the excellent clinical outcomes, the survival and lack of osteolysis, the clinical significance of these radiolucent lines is uncertain. This table just compares the results of this study to those looking at midterm analysis, as well as a slightly older population with the longer term follow-up. And what it demonstrates is that there's a comparable low rate of polyethylene wear, low complication rate, and high survival with our longer term follow-up. This study does have some limitations. So first, 3 different femoral head materials were used in this series, and the study itself was underpowered in order to determine a superiority of one counterface material versus the others. Another limitation is the variety of femoral head sizes used, as well as the predominance of the 28 millimeter head size. Our rationale for selecting head sizes was to allow a polyethylene thickness of approximately 6 millimeters. And studies have since shown that polyethylene less than 6 millimeters is safe and has not been associated with excessive wear or fracture. And then lastly, perhaps most importantly, we did not obtain CT scans on patients for comprehensive evaluation of osteolysis. We didn't see osteolysis on the radiographs, but perhaps that may be an underestimation without quantifying with CT. So in conclusion, this investigation represents the longest clinical follow-up of a large consecutive cohort of patients aged 50 years and younger with total hip arthroplasty using highly cross-linked polyethylene. And it found negligible polyethylene wear, no incidence of aseptic loosening or osteolysis, and excellent clinical outcomes at beyond 15 years of follow-up. We were published in the British Bone and Joint Journal in July 2021. And the next steps with this patient cohort will be to do a 20-year analysis, looking at their outcomes. Thank you, and I'm happy to take any questions that you may have.
So Gordon, what are you gonna do with that 30-year-old person that comes to you, has a BMI of 39.5 and has severe arthritis?
So if they've truly got severe arthritis, this data makes me feel a little bit more comfortable about being able to do a total hip. Now, I think in any indication or any instance, I'm going to try to exhaust non-operative measures before I do total hip. I don't think that this is a panacea that says that we can just put a total hip arthroplasty in any patient and they're not going to have any issues going forward. I think we still have to be pretty selective. I think we have to think about things like nutrition, about obesity. You know, there's more factors that go into it than just the polyethylene is what I mean to say.
If you think back to when this, so cross-linked polyethylene kind of introduced in '98, so this kind of started then. So I think there was a lot of anxiety about the long-term result going to be because it was a new material.
Yeah.
But of the new materials at that time, at least it was material that if it failed, we knew what the result would be.
Correct.
As opposed to metal ion release and ceramic.
Yeah.
Very good study.
Thank you.
Yeah, I'm a total ankle guy. But
What do you think of cross-linked poly with your ankle?
well, we follow the joint guys. So we're always happy to see long-term follow-up with hips and knees that aren't showing a lot of loosening and poly wear because we're just not far enough out with our data collection and we don't have anywhere near the numbers that the hip and knee guys have. But it's always encouraging. Our average age, there's a minimum age in our world that around the country kind of hovers around 60. And I think it probably did that in total joints back in the 70s and 80s where you just knew they were going to wear out 5 or 10 years. But every time a paper comes out and gets published in a major journal that contradicts that and maybe brings that down, I just think it gives so many people more options. And whether it's a combination of really good surgery, very low infection rate, very low dislocation rate, good biomaterials, maybe it's the biomaterials that are getting better. I don't know, but there's a lot of experience in total hips and total knees that I think the rest of the orthopedic community is really drawing after. And that goes to all aspects of it. We're using your DVT data. We're using your early mobilization, your early weight bearing data, because the numbers are just so much more significant. So I think that's a great study you did. Congratulations.
95 to 2005, there were so many changes went on in arthroplasty. Some of those changes, other than that, cross-linked polyethylene. Questions, comments, please? We have a comment or error. One of the problems of the early problems with hydrocortisone was the compromising mechanical properties with crossing. Right. That was a concern, and that was solved eventually technologically by stabilization with antioxidants. I presume this is with an antioxidant too, not compromising mechanical properties. And when you start introducing the ankle, so I have a question for Dr. Andersen. I'm amazed at how the ankle sees almost the same forces as moving hips and smaller contact areas, so the stresses are higher. And therefore, theoretically, that risk of using highly cross-linked poly with potentially compromised mechanical properties should be more regarding disease. So have you ever thought of that concern? Where is the ankle community regarding that? Yeah, probably has to do with the surface contact area too, is completely different, right?
Yeah. So I'm old enough to remember the agility was probably the first implant that gained popularity in the United States, and that implant resurfaced into the fibula to try and gain more surface area. So you had to do a syndesmotic fusion just to prevent that motion segment across the syndesmosis. And the goal was exactly that. We need as much surface area as we can. The bones are fairly small. And we also have blood supply issues down in the ankle that we don't deal with in the hip and the knee. So you got a talus bone that gets its blood supply from several areas. And many times they've got subtalar arthritis, and that may have been violated with a subtalar fusion, and the talonavicular joint gets worn. So we're doing total ankles in people with some real complicated deformities and some complicated combinations of arthritis, and the blood supply to the talus gets compromised. Yeah. So we haven't been able to get far enough out to think about polywear as the main source of failure. And we're just now getting to that point where we've got good 10-year data that shows implant stability, good alignment, good ingrowth, and we're starting to see polywear for the first time. Usually it's catastrophic failure early in the first few years. Yeah. So again, we don't have enough data. We're all using vitamin E impregnated, highly cross-linked, oxidized polyethylene right now, but in the first 10 years, that's the least of our concern because we're still trying to get through the initial learning curve.
Good. Thank you. Thank you, Lord.
Batting cleanup from Kansas. Dr. Tingle, Kansas undergraduate medical school here for orthopedics. He'll be going to San Diego for a sports fellowship, and you need to all wake up because this is a very important topic of sleep deprivation. Matt?
Thank you. Thanks, Dr. Garvin. I know everybody's on pins and needles for this talk, so let's bring it up here. All right. Thank you, Dr. Andersen, for coming down here to listen to us to present today. Special shout out to my dad who's here today and my family listening on Zoom. So my name is Matt Tingle. I'll be presenting our study sleep improvement program and academic performance. Me, myself, and RJ Barber, Kari Nelson in the GME office, Liz Wellsant, Dr. Koningsberg, Liz Leiden, our statistician, and Dr. Tao. Here are our disclosures. Actually, I do have one disclosure. I do love sleep. As you can see, I even like falling asleep while eating pizza when I was a kid, one of my family's favorites. So that is my disclosure. I do want to actually acknowledge the UNMC Medical School for actually funding this project. This would not have been able to be performed without their funding. So we are a special shout out to them. So we'll talk about sleep and healthcare, the purpose and the methods that we went about for our study, as well as the results that we found and the conclusions we can draw from it, and then future directions for this topic. So as you might imagine, as everybody in this room probably knows, sleep deprivation in medicine is a growing topic. It started in the 80s and 90s, and in 2003, the ACGME made changes to the work hour restrictions, kind of a global regulations, making it so you could only work 24 hours plus 4 hours at the end of the shift for a handoff, as well as you could only average 80 hours of work per week over a course of 4 weeks, and then you needed 1 and 7 days off between that. And then they even went a step further in 2011 and said, okay, well, the first year residents can only work 16 hours, 24 hours for everybody else, but you had to have a minimum of 14 hours off in between shifts. In 2014, 2015, the first trial was performed, which was over 120 different general surgery programs across the country. And they took what was initiated by ACGME in 2011, they took half of them and applied that. And the other half, they said, there's no restrictions whatsoever. And based off what they found in that trial is that there was a non-inferiority of patient outcomes, patient mortality, and overall resident wellness. And so in 2017, the ACGME went back and said, okay, well, based on this data that we have, we're going to go back to 24 hours plus 4 hours for everybody. And then you just have to have 10 hours off in between, keeping with the 80-hour work week and 1 and 7 days off. So what is optimal sleep? So if you look at the National Sleep Foundation, optimal sleep for anybody 26 to 64 years old, which is probably most people in this room, is about 7 to 9 hours of sleep. And if I probably asked a lot of you, you probably don't get that much sleep per night. So what is sleep deprivation? So according to the American Academy of Sleep Medicine, acute sleep deprivation, which is a few days or less as they define it, is significant reduction in sleep time. Chronic sleep deprivation, which is what most residents have, aka insufficient sleep syndrome, is sleep restrictions that persist for greater than 3 months. So what do we know about it? So chronic restriction of sleep, which is about 4 to 6 hours per night over the course of 14 days, has a significant cumulative dose-dependent deficit on your cognitive performance on numerous tasks. And we know that Psychomotor fatigue, which is your fine motor movements, your ability to control your body in space, is affected most by sleep deprivation. So how does that affect sleep in medicine? So there was actually there's a couple of studies several years ago. One was very interesting that people like to quote is they actually took intoxicated surgeons above the legal limit of alcohol and sleep deprived surgeons coming off a 24-hour shift, excuse me, and they had them perform laparoscopic techniques on a simulated lab. And they actually showed that intoxicated surgeons were faster at performing things compared to sleep deprived surgeons. But there really isn't any as far as evidence to inform kind of the issue of how this affects surgical performance. So there's a lot of unanswered questions as you have this 2011 reform that the ACGME implemented on duty hour restrictions. And it really didn't show anything as far as per the first trial that there was any improvement in patient care or resident well-being. A lot of the literature tends to focus on this negative effect and then the negative detriment that this hour restriction has and regulations have on graduate medical education. But there really hasn't been anything done to kind of spin that and say, okay, well, if we can show positive correlation or show that sleep can actually improve how you perform, maybe we can get better outcomes for our patients, be able to perform better. And so that's where this kind of spurred from. And then you add in this article by Sherry Ma in the Sleep Research Society Journal in 2011. So what she did is she took the men's and women's D1 basketball programs at Stanford University, and she collected their baseline sleep data for about 4 weeks, and then implemented a sleep extension program the next 5 to 7 weeks after that. And she used basic sports statistics, looking at their sprint and sprint times, shooting accuracy, free throw accuracy, 3-point field goal percentage, et cetera, as well as their reaction time, and then evaluated their overall sleepiness and their mood. And what she found was that as their sleep increased, they had faster sprint times. Their free throw percentage and 3-point field goal percentage went up by almost 9%. Their mean reaction time improved, and their sleepiness scores decreased, and their mood improved. So they concluded in their study that this sleep extension can actually boost your performance, and that optimal sleep is beneficial in achieving that peak performance. Well, that's great. Well, that's athletes, right? So how does that even relate to physicians? Well, if you look at all these athletes at the kind of peak of their game, LeBron James, Roger Federer, Serena Williams, excluding Tiger Woods, but we are able to see that they get anywhere from 10 to 12 hours of sleep. And so if these people that need to perform at the highest level have to get this much sleep compared to what the Sleep Foundation tells you, maybe there's something to that, considering we're taking care of patients in critical situations, life or limb situations. We're making profound impacts on patients and under stress daily. And so this is something that maybe there's something similar. So here comes where our study comes into play. So we wanted to investigate the impact that improved sleep quality and extension can have. And we started with something simple, which is what we could measure in first-year medical students here at UNMC. So what we wanted to look at is their primary outcome was the raw test scores. And this was based on the standard examinations with the UNMC curriculum. And then our secondary outcomes were going to be mood evaluation using the profile mood stage, which I'll talk about shortly, and the Epworth Sleepiness Scale, which I'll also talk about shortly. So our hypothesis was that improved sleep quality and extension will significantly improve test scores, mood, and daytime sleepiness. Makes sense, right? So the way that we went about this, initially we set out to get 20 first-year medical students. Unfortunately, we were unable to get that many students when we essentially presented to the entire M1 class here what are kind of a general idea of what we were doing. We didn't tell them exactly what our final outcomes were looking at, but we wanted to kind of give them kind of, hey, this is what we're looking at. Are you interested? So we unfortunately only ended up with 6 first-year medical students that were willing to participate. And this enrollment was purely voluntary. We unfortunately did lose one of the medical students to incomplete data, which I'll talk about in a little bit. So we ended up with 5 total. This was over the course of the spring 2020 semester, so 10 weeks. So we got 4 weeks of control data and 6 weeks of intervention data. And then we had the subjects log their sleep in a sleep diary for quality control. So they wore these actigraph monitors on their 24/7 on their dominant wrists. It's kind of like a Fitbit on steroids. It has accelerometers in it. It has devices that can track their ambient light. And so we were able to monitor that and have that on them for the entire time of that 10 weeks. And then we got their grades from the spring 2020 semester. We had their sleep logs. And then we had the Epworth Sleepiness Scale, which is a survey that we gave at the beginning and end of semester. So we had 2 of those total. And then we had our profile of mood states, which we gave weekly. So we had 10 of those total per subject. So the Epworth Sleepiness Scale is a self-administered questionnaire, and it's actually been well validated and studied to determine the general daytime sleepiness of subjects, whether they're performing simple tasks like sitting here and listening to me talk, watching TV, driving to work. And it was a scale of 0 to 3, 0, no chance of dozing off, 3, a high chance of dozing off. And so it's actually been studied fairly well and been used commonly in sleep studies. And so we were able to use that in our study. And then the profile of mood states is a little lengthier. So this was given weekly. And so this had 65 mood descriptions that they went through and said, I'm not at all likely to feel that mood, or I'm extremely likely to feel that mood. And then this calculates it based on these 6 subscales of tension, depression, anger, vigor, fatigue, and confusion, and calculates a score. The lower the scores, the more stable their mood and less likely to have mood swings. So for the 4 weeks, we had them do self-selected habits, take their sleep logs, do their surveys. And then we implemented our intervention, which was a sleep hygiene improvement through the actual intervention itself was a PowerPoint. Here's one of the slides from our PowerPoint that we gave to the subjects in our study. And then weekly, when we sent out the profile of mood state survey, we actually reminded them to encourage them to continue to work on sleep and kind of reinforce that, essentially coaching them along the way. So we were able to take all that actigraph data and the sleep diaries, and we compared them for accuracy. And then we took the actigraph data and used what's called the Cole-Kripke algorithm, which is the software that comes with the actigraph that's also been well validated and studied. And we're able to withdraw information like how many times did they wake up, how was their efficiency, how long did it take before they fell asleep, how long did it take, or how long were they awake when they did awake in the middle of the night, things like that. And then so we were able to take all that information and we used paired t-test in order to compare the pre and post intervention differences in those different data points. And so here are our results. So what we found is that our primary outcome, which was the subject's grades, they actually statistically significantly improved from 96% to 92%. Our secondary outcomes, the Epworth Sleepiness Scale scores changed and dropped 2.6 points, which was statistically significant. And the mean clinical important data, meaning the data that you needed in order to prove that it was a significant change, is -2 to -3. So this did fall in the range of clinical importance for that score drop. Our profile mood states score did drop 4 points, but this was not in a statistically significant manner. But we did have a decrease in their mood, which is a positive thing. And then if you look at their actigraph data, their number of awakenings, interestingly enough, did increase per night. So that was statistically significant, but their total time in bed did increase and their total sleep time did increase, but these were both not statistically significant. So what does all that mean? So I think from that data, we were able to say the sleep improvement program significantly improved the raw test scores and the daytime sleepiness in first-year medical students. We were unable to conclude that this changed their overall mood in a statistically significant manner, but we did see improvements in their overall sleep time, time to bed, things like that. So advantages of this study is we'd actually had 100% actigraph and sleep diary compliance of our subjects, which was awesome. We used clinically proven and validated monitoring systems, including the surveys and the actigraphs. We were able to avoid recall bias by quality controlling those actigraph data to the sleep diaries. And we were able to implement kind of what we set out to do and successfully study it. Obviously, there's going to be some limitations with this study. It's a small pilot study. We only had 5 subjects. We had small enrollment. Some of that's probably because these subjects didn't really want to wear this bulky device on their dominant wrist 24/7. The grades comparison is, I think, something that we're currently working on. So if you look at their grades, they improved from the first half of the study to the second half. Well, is that just because the second half of the semester was easier tests, or was that because the first half was a harder test and that's the reason it improved? And so what we're doing is we're actually talking with the medical school to see if we can get the averages for the entire medical school or the entire class over that period and compare them. There's obviously some self-selection bias in this study. These subjects, were voluntarily enrolled for the study. And then there's obviously the observer bias as well. They know they're being monitored. They have this giant the device on their wrist monitoring their sleep. So they kind of know generally what we're trying to look for. So there's a potential for that observer bias. So future projects, I think that there's something here. I think that If we can get to more fashionable, sleeker devices that they're more willing to wear and that they can wear for longer periods of time and collect the same amount of data, if not even more, I think that's something that we could look at. Obviously, I'd like to use it on a bigger group and for an extended period of time. COVID had a negative impact on that as well. And then you can implement it into surgical specialties and then start looking at their overall performance on arthroscopic simulation or their basic skills. So that's something that you can use with this as well. So I've presented this at the podium for the UNMC GME Research Symposium for a few years now. Plan is to prepare the manuscript and then submit to AMC, CEA, MAOA, and American Academy of Sleep Medicine. And then hopefully, like I said, is to apply this as a pilot study that can be used across the field of medicine and medical training. Once again, thank you for the UNMC Medical School for funding this. Here are my references, and I'll gladly take any questions. So that's one of the things. So there's a couple devices. I don't know how many people are familiar with Whoop, but I've actually contacted Whoop, and that's a device you can actually hook to your bicep or your ankle, and it actually monitors the exact same stuff. It's not as studied as Actigraph is, but you can monitor oxygenation, heart rate, and things like that. And so that's something that you can just move from your dominant wrist to the bicep, and they've shown that it's actually the same. There's no change in the data. So I think if you're going to do that, like you said, if you're going to do it in surgeons, you should do it on something where you can wear it still while you're operating. And then you could actually even track like the stress you're under while you're operating, your heart rate variability. I know there was a recent study in arthroplasty showing that you have the most cardiovascular intense exercise when you're putting in a total hip. There was a recent article that came out about that, and that's kind of similar how they studied that. So.
That's good. Okay, congratulations. Thank you. Good, very good session. We're going to turn it over to some of the research things we've done. Dr. Andersen, Dr. Matt Halanski is Vice Chair of Research. He's done a great job the last few years, kind of shepherding us in the right direction. So I'm going to have him introduce this, and then we'll give you a little potpourri of the research we're doing. Matt? And Professor now. Just promoted.
Yeah, just promoted. Thank you. Yeah. Hello again. I don't know if you remember, your partners wrote me letters for residency, so I spent some time in Grand Rapids. So good to see you again. First up is going to be Hani. Dr. Haider is going to share some a little bit of two different things. Some work that he's been doing on some mechanical testing of shoulders, I believe. That's very brief. And then he's going to talk much more about some dual mobility hip work he's been doing with industry on. We'll start us off.
Thank you very much. Thanks for inviting me to talk, and I enjoyed the previous talks, and congratulations to all the residents who are graduating this year. I will start with something very small. And my challenge is not to get bogged down in detail so that you get the full picture and not to ruin the timing for all the other talks in this small session. So this is teamwork, and this is the arthroplasty kind of research team and in the lab. So we all contribute to this. In terms of disclosures, I take this very seriously. Our lab is open. We've done over 93 projects in the last 20 years with over 34 companies. So the message from that is that we're not aligned to any company. So there are no marketing links that we have with companies. That's good and bad. We're free, we're objective, they know we are, but also it means that we struggle for every dollar we get because we are not aligned with any company. And those of you who know what I mean know how difficult that is. So these are the companies on the left for which we've done one or more contracts in the last 20 years out of 90. So some of them we've done 4, 5, 6. We've also got some consultancies, and we also have, I mean, these are basically just mine. It becomes very complex to add all the other teams people. And we have small contributions to NIH grants. I'm going to go a quick excursion, like Dr. Halanski said, into something very simple. We're contributing to a big complex NIH grant on 3D bioprinting, if you like, to repair constructs of rabbits, tendons to shoulders. The idea, the technology here is to use the fact that we can bioprint scaffolds in multi-layers and grade them. Imagine a scaffold that has different characteristics near the bone versus near the tendon. And you could make those different in topology, in shape, in layers, and also add biological things to them by hydrogel printing to different compositions. Imagine the recipe, the juice you add in terms of mesenchymal cells, etc., could be varied depending on where the region is. So bioprinting, 3D printing opens up all that. And this is a collaboration with Dr. Duan Bin, who's a tissue engineering person, and Dr. Strubel, who was with us full-time in shoulder surgery. My contribution, our contribution in the lab, was to test their final construct on rabbits. So I'm going to start from here because otherwise I'll get bogged down in what this biology and chemistry. Bottom line is, does the gear work? You could do things and things and things, and there are hundreds, if not thousands of papers. By the way, a lot of it doesn't work if you read the literature. I mean, that's very simple. That's the conclusion yet. But the interesting thing is how they are testing and how they're evaluating. And if it works, will it work forever in the patient? I mean, these are very interesting questions. But in the perspective of somebody like me in the lab, how to test it, we've got millions of rabbits, like 92 shoulders of rabbits and 2 shoulders from each one. After the treatment, if you like, we have 5 groups, one with just a sham control, that's the rabbit intact without any defect in the interface between the tendon and one with defect only, untreated, like healing. The third one is with the bioprinting without fuel, if you like, biological fuel, just a graded construct. And the third one is with some type of cells, and the other one is with different types of cells. So 5 different things. And we test them mechanically, very simple machine. This is like, these machines are 10 a penny in every biomechanics lab, just simple axial. But we had to really understand and struggle how to hold a harvested tendon correctly by freezing parts of it, by keeping the other parts not frozen, so it behaves like almost like physiologically. And these rabbits are unfortunately dead, of course. So it makes it complicated. But we test those groups and compare them. And I'm just very quickly, as I said, I don't want to get bogged down in detail. On the very left of these graphs, this is the sham control. This is how it is intact without defects, without the injury. The next one is injured and self-healing, if you like. Then the green is the technology with the graded 3D bioprinted hydrogels, graded blah, 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 highest technology. On the 2, blue and orange, these are that plus some biological fuel, different types of cells to encourage bone growth, et cetera, again, graded differently from in different regions of the construct. And notice that apparently the mechanical bioprinting, changing the topology mechanically, physiologically, geometrically, if you like, grading it near the bone, the scaffold is differently made, gradually becoming different near the tendon. It's giving us a huge improvement. Like, look at the green compared to the gray. Now, what's interesting, and that's when it gets very biological, the biological fuels, if you like, different types of cells, different dosages, and so on, they're adding very little. And this story, by the way, is repeated in the literature a lot. And I wonder whether even the green itself is truly better for the life of the patient or the rabbit if they were to live for a long time, because it's okay to prove for the sake of a paper that you have some improvement mechanically. The problem with what you guys do is you try to treat the patient for a long time. It's not a matter of, oh, the results are great, goes into the paper. The patient has to still be okay. The implant has to still work. The repair has to still work for a long time. And this is the challenge for the tissue engineering people. I promised I'm not going to talk. The conclusions are on the screen. You probably know more about the biology than I am. And I'm going to just leave that and go to something I know much more about. Now, dual mobility hips, and we are arthroplasty people. I mean, a lot of my lab staff and I, we have 2 current studies out of maybe over 60, 70 we've done over the last 20 years. We've tested for all the blue chips and medium-sized companies. Dual mobility hips are a new thing. And it's a funny story. I won't have time to tell you why they came up. They came up in reaction to the metal on metal saga. It's a way of revising bad metal on metal implants without revising every component. Dr. Garvin knows a bit of that history, but it inspired some design input to maybe provide advantages. But here is the idea that you'll have almost like a mobile bearing knee, but in a hip. You'll have two articulating surfaces. You have the tan-looking bearing floating. It can articulate on the inside and on the outside. This is good and bad, and that's the purpose of this slide here. It is good in that with that bearing being able to move, if I reach an extreme of motion, like high flexion, high abduction, and or high internal external rotation, and the combination is deadly, especially in a misaligned installation, which most hips are, because surgeons, not all of them are totally perfect, like Dr. Garvin and our people here. What happens is this bearing can shift out of the way and stop impingement. We call that in engineering edge loading, which can have damage to the rim. And also it could cause subluxation, which you've studied in. So this is a good thing. It's an adjustable design that allows you to reach the extremes of motion without causing mechanical damage. It's a bad thing theoretically, because those of you who've read about literature about polyethylene wear would know that bigger hips in diameter wear more. And I'm going to link this synthesis in these talks, by the way, even on a seminar like today. It's very difficult linking the information from two talks on completely different subjects. So I believe that the problem about low contact area and high stress in polyethylene was a problem of the past. That was fatigue-driven wear due to high stresses, because most of the polys before the 2000s were sterilized in air, not in an inert gas, and they oxidize very quickly and they fatigue. What's left after that, whether it's highly cross-linked or not, are polys which have been sterilized in an inert gas. They don't oxidize, they don't fatigue. What's left is what we call adhesive wear, normal removal of material due to rubbing. And the polys are so good. In fact, now, increasing contact area, this is an award-winning paper in the AOS a few years ago, that we showed for the first time from our lab that actually higher contact area, reducing stress, will increase wear. Reducing stress by increasing contact area will increase wear. So the message is good polys need not to have their stress reduced because they're all very good and the stress is good with good design implants. You increase contact area, will increase wear. So bigger hips wear more. That's not a surprise. So now if we have this technology and now add another articulating surface on the outside, which is big, by the way, compared to the inner surface, we should be increasing wear, and that's a concern. So the questions that we ask on the bottom, with having to increase wear, where does the wear come from also? Does it come from the outer or the inner? So we have done two series of tests. One of them I'm going to report here and then digress and go to the other one very quickly. We've tested a full dual mobility, simulating a patient walking for 5 years, and then compare that to a normal fixed bearing hip. And isolated with some innovative fixturing, and I'll show you them, we simulated the dual mobility which cannot articulate on the inside, just the outside, and one where we could just articulate on the outside and not the inside, and compared all these three groups with a fixed bearing. And these groups are in those colors, and they're going to keep on those colors in the graphs and the results. These are some fixtures which we make in our lab, by the way, which is on this floor, 20 yards from here. You can go and see it for those of you who haven't seen it. And I'll show you a picture of the lab in a minute. So this is an example for the outer articulation fixed. Can you see here, we have made some fixtures, made them in stainless steel and titanium to fit into the bearing without allowing the inner to be a hip that rotates. So we're fixing, we're locking that. This hip can only rotate on the outer, dual mobility rotating on the outer only. Now, this is the opposite. This is one we made the bearing, identical geometry from the inside, and made it of the same material, highly cross-linked poly, but it can only articulate on the inside. Can you see this ball here is fixed? It cannot rotate on the outside. So it's interesting to see which one would wear more and less. And of course, the dual mobility is normal and the fixed bearings normal as you know them. This is our lab. This is about a 5,000 square foot laboratory on this floor. If you want to see it from the windows, you can go and have a look here. And we have a simulator room. And that simulator room has got more equipment for testing implants than any other academic lab in the world, in the middle of Omaha, Nebraska. I can't believe how we did it here. But anyway, so the hip simulator used is this, simulates a patient walking for about 5-10 years. And the walking cycle involves flexion, abduction, adduction, internal external rotation, and forces similar to the human based on an international standard that we help write. These are the waveforms. I'm not going to bore you with them. These are verification that the waveforms are applying to all the groups equally, flexion, extension, forces, multiple body weights reaching during weight bearing, abduction, internal external rotation, and flexion. These are what the bearings would look like. The devil is in the detail. We could show pictures, but I'm just going to skip through those very quickly. Interesting, this is the cobalt chrome with the outer articulation only. We have a form of wear, a mode of wear called abrasive wear, no matter how clean the patient is. And even in a simulator where it's even cleaner, you get some tiny particles which will cause scratching, and that adds a lot to the wear. So this is the result. After a year of work and 2-3 people full-time, literally, you get these results. The higher the wear, loss of material, the more the risk of osteolysis. Remember volumetric wear? This is gravimetric wear. The difference between the two is just density, it's a constant. And the density of poly is almost 1.92. So let's make another link to a previous talk. Remember the clinical wear results? You said 6 millimeter cube per year. Was that right? Isn't it interesting, whoever said it, that we're measuring the same thing in the simulator? Look at that. This is so much per million, which is per year. It's amazing, amazing. And people say simulators don't work. So we could, on the bench, simulate in a $100,000 contract in about a year what's happening in the patient. Green is the dual mobility, literally nowhere, very little. Fixed bearing as a standard is that one. Can you see that? Fixed bearing, it's much more wear. And that's a 44 millimeter hip. Now, if you do the outer articulation only, it gets much more wear. It's acting as a rotating bigger hip. And if you do just the inner, you get that. So the dual mobility bearing is lower wear than a fixed bearing, and even the smaller inner. It means it's not rotating on the outer. And it means it's also working out as a mobile bearing. So I'm going to now conclude with a 2-slide digression. The same study was repeated with another completely different design of dual mobility, same results, same results. So the answer is those dual mobilities do not offer a risk of higher wear because of the outer bearing. And maybe they're working like a mobile bearing where they're decoupling rotations to reduce cross shear. So they are less risky than people thought. And that's what I conclude my message with you today. Thank you.
Thank you, Hani. I don't know if anybody has any quick questions for Hani. We'll grab next is going to be pulling it up here.
Yeah. No, yeah, I hope that's
I
it.
think so. We'll see.
Yeah, that's it.
Okay, so next speaking to us is Dr. Scherl, one of my partners on pediatrics, and this is a project that Aaron, one of our residents, has worked a lot on, and the peds group has worked on, trying to define what is a pediatric trauma patient. So.
Yeah, so like Matt said, our study is called Pediatric Orthopedic Trauma, What Defines Pediatric? And Dr. Stockwell actually did the lion's share of the work on this, and Dr. Hasley as well. So here are our disclosures. So trauma is the leading cause of morbidity and mortality in children. And actually, as of pretty recently, it's gunshot wounds. There is a good amount of literature to support the idea that there are better outcomes in pediatric trauma cases when children are brought to pediatric trauma centers versus adult trauma centers or community hospitals. And this highlights the importance of the idea that, you know, children are not just little adults and have unique physiologic characteristics, but that kind of begs the question, where does childhood stop and adolescence or adulthood begin? And how should we define pediatric orthopedic trauma? Should we define it chronologically based simply on the age of the patient? Or should we think of it a little more physiologically based on whether or not their physes are closed? And this was sort of born of sort of a practical problem in that most children's hospitals will treat patients up to a particular age. Their cutoff is 21 or 18 or whatever it is. But from an orthopedic point of view, you know, a 21-year-old is not really a child, and they don't get the same kinds of surgeries and the same kinds of treatments as a 5 or 6-year-old does. And that's different for other things. If you talk to a pulmonologist, a 21-year-old with cystic fibrosis gets the same treatment as a 5-year-old with cystic fibrosis. So for them, it doesn't really matter. For us, it's a little different. So we wanted to find out how other pediatric orthopedic departments in leading children's hospitals do this, and how they manage skeletally mature patients when they come to them. So we did this in 2 parts. And the first part was a 19-question online survey. It had a variety of multiple choice, yes and no, and open-ended questions. And we sent this to one designated POSNA member within the orthopedic department at each of the 2019 top 50 children's hospitals as per US News and World Report. And we chose one person within each department who we know does trauma. And for this part of the study, we had a very high response rate. We had a 96% response rate. We got 48 out of 50 of these things back. 45 of the respondents said they worked at a level 1 or level 2 trauma center. 40% were located on the same campus as an adult level 1 trauma center. 60% were freestanding like we are. The majority, 78%, defined peds ortho trauma by age. The mean upper age limit was 18, but it ranged from 14 to 26. The other 22% did define pediatric orthopedic trauma physiologically based on whether or not the patient had open physes. And 15% of institutions included non-pediatric orthopedists in the call pool. So they had an adult person with them. When we asked them about specific types of fractures, unsurprisingly, everyone said they took care of skeletally immature long bone fractures. Almost everybody took care of long bone fractures in skeletally mature patients. When we asked about things that were a little more complex, periarticular fractures, again, everyone took care of skeletally immature patients. That's what we do. But the number of people who were taking care of skeletally mature patients dropped down a bit. And then finally, we asked about operative pelvis and acetabular fractures, and there was a big drop there. In the skeletally mature patients, almost nobody was taking care of those. We then asked, if you weren't taking care of these patients, what happened to them? And 25% of them needed to be transferred to another facility. The other 75% either had someone on hand who was an adult traumatologist, or an adult traumatologist would come in as needed. So our conclusions from this part were that nearly 80% of leading peds ortho hospitals in the US define trauma by age and not physiologically. And that about 50%, or greater than 50%, manage complex periarticular and long bone fractures in skeletally mature patients, but almost nobody is taking care of pelvic and acetabular fractures in these patients. So the limitations of this was it was a survey. It was only 50 institutions and 1 response per institution from an institutional representative. So then we wanted to look at this a little more on an individual basis and see what individual POSNA members treated, what types of fractures and what age ranges. So we devised a slightly different questionnaire. It was 30 questions, multiple choice. It was sent out via RedCap, and it was sent to all 1420 active POSNA members. It was approved by the IRB here. It also went through the POSNA Evidence-Based Medicine Committee, and they were the ones that distributed it via email blast. We collected information about respondent demographics, their practice information. We asked some general questions about the types of fractures they treated, And we had 5 questions in which we included x-rays and asked about the treatment of very specific fractures with these radiographic images. And I'll talk about that in a second. Unfortunately, for this part of the study, we had a really low response rate, only 7%. There were 99 completed surveys out of 1420 people that we sent it to. Our results were that 61% of the respondents had been in practice more than 11 years. Unsurprisingly, 98% had completed a PEDS fellowship. 4% had also completed a trauma fellowship. 7% identified as OTA members as well as POSNA members. And 56% reported a special interest in trauma. And I can tell you that that is not the case across POSNA in general. If you ask the 1420 members how many have a specific interest in trauma, you will not get over 50%. So this was a little bit of selection bias right here. In this cohort, there was even a higher percentage that defined PEDS trauma by age. Greater than half used 21 as the upper age limit. But 91% of these people said they had adult trauma coverage at their hospital. So they have an out if they don't want to do it themselves. And about half treat fewer than 20 operative fractures per year in a skeletally mature patient. And 30% would prefer to limit their practice to skeletally immature patients. There was a trend, though it wasn't significant, of the longer one had been in practice, the less one wanted to take care of skeletally mature patients. So these were the 5 scenarios in which we provided x-rays. We had an operative pelvic fracture in an 8-year-old, an acetabular fracture in a 16-year-old, a T-condylar humerus fracture in a 15-year-old, a tibial plateau fracture in a 16-year-old, and a Lisfranc fracture in a 16-year-old. And we asked them, you know, here are the x-rays. Would you provide all provisional and definitive care, care in conjunction with somebody else, provisional care only, or would you just not deal with this at all? And the takeaway here is that pelvic and acetabulum really are sort of hard stops for most pediatric orthopedists. You know, over 50% will take care of some of these other things, but no one really is taking care of operative pelvic and acetabular fractures. So what we concluded from this was what I just said, that most pediatric orthopedists do not provide operative management of pelvic and acetabular fractures in either skeletally mature or immature patients. Our limitations here, we had a poor response rate, and I think there was some significant selection bias. There has been a real demonstrated increase in the volume of pediatric orthopedic trauma and the rates of pediatric orthopedic trauma referrals. There is a growing concern that there will be a shortage of fellowship-trained peds orthosurgeons in the coming 10 to 20 years. And you know, it's possible that defining peds ortho patients physiologically may facilitate improved patient outcomes, you know, lets us see the patients who we're really trained to take care of, and could offload the burden of some of these things that we're really not as comfortable treating. And that's about it. Any questions or comments?
Certainly points to the fact that there's no slope, and if based on the skill set and comfort level of whether they're you know, so be able to sort of announce
Yeah, I know. And it's funny though, you know, we started this partially because, you know, when we go to meetings and we talk to people anecdotally, you hear a lot of people sort of saying what we're saying, you know, I don't really do it. I'm not comfortable doing it. I haven't done it in a long time. You know, I would rather take care of everyone, you know, skeletally mature and send these 16, 17, 18-year-olds to my adult partners. And then when you send out the survey, everyone's like, oh yeah, I do that. I sort of, you know, I sort of felt like, I don't know. I was a little surprised by what.
21 years
Yeah.
They take care of 10 to 20 pediatric cases, like 60.
Right. Right, and that's what sort of, makes sense when you think about, but we couldn't get that out of the data, basically. Exactly.
And the study here, there are numbers here, about 7 to 10 people go from here to shoulders here, about 7 to 10 people go from shoulders here.
We're all tagging on 72nd Street as
And you're correct, Paul, it really is a wash. It ends up being about the same. But
and it's, I mean, and we all are. If you drive fast, 7 minutes. If you drive
All right, thank you, Susan. Next up is going to be Matt Tao. He's going to be talking about some updates on some of the sports medicine research going on in the department.
Thanks, Matt. Well, I'll try to keep it quick here. We won't get into the weeds too much. Certainly congratulations to our guys that are graduating, and to Dr. Andersen, appreciate you being here, and to the families. I'm going to go over our updates as far as our team in terms of what we're doing. Really nothing relevant as far as disclosures. This is semi tongue in cheek, but the reality is that Liz Wellsant, who's not here today because she has an NIH grant session this morning, is really the head of everything that we do. She is fantastic. Many of you that are in the department know her. She does a really, really good job. I'm just very grateful that she lets me kind of hang on to her coattails with this. So I put this slide up a few years ago, probably 3 or 4 years ago. The University Foundation came up with this thing called the Big Ideas Grant that we submitted a proposal. Hani did, Sergio did. We did not get ours, but one of the things that was fun in that was it was very collaborative with other places within the university system. And our idea centered around health and wellness, and that had 3 tenets in terms of physical well-being, mental well-being, nutritional health. And so we still, even though we didn't get funded, I think it has helped influence a lot of what we do. And in orthopedics and in physical therapy, obviously we focus a lot on the physical movement side of things, but definitely the mental side of it is really important. Some people, Austin's here. Austin's done some work on this during his year in the lab in terms of mental readiness for return after ACL and things like that. So the mental side of it's really important. There's certainly been things published on that in a variety of domains within orthopedics, but I do think that's a big part of it. But most of our work centers around the knee and specifically the ACL. I'll just go over these relatively quickly. Just to set the stage, you all know ACLs are common, close to 250,000 of these a year. And in terms of what the issues are, I think frame it in terms of short-term consequences and long-term consequences. We all think about getting back to sports, and that's a really important part of it. Let me see if this will work actually. Yeah, good. So that is a really important part of it. Most of these that happen in, young active people, even if they're not quote unquote high level athletes, we want to get them back as safely and effectively as possible. And so you frequently see in the news an athlete will tweet out and say, I'm going to be back and stronger than ever. But if you look at the data, that's really not true. Only about 3/4 of them even make it back to sports. In terms of getting back to the rate and level of sport that they were at before or better, it's really a coin flip. If you look at the rate of return, as far as the professional leagues here, these numbers are not great, right? We take it as a foregone conclusion. You had an ACL, you'll be back, it'll be fine. But the reality is that's not totally true. And this is what we really want to prevent. Even though he's not with New York anymore, it still pains me to see Odell go through a second injury. These are devastating for young people. You have a second ACL injury, the implications of their ability to get back to activities and their long-term health and longevity of that knee is really poor. And so we have to find ways to get people back safely and effectively and in a timely manner. The other thing long-term is kind of the anti-Kevin Garvin effect, trying to avoid knee replacement in young people when they can, regardless of if polyethylene wear is good. We want to try to prevent that. And so we know that these people get arthritis at a much higher rate. And so at 10 years, ballpark 50% of people have some arthritis, which is 8 times higher than they normally should. Get 20 years out, 80% of people have some radiographic signs. This is one of my guys that's 53, and he played college football, had a ACL tear, I think maybe 2 ACL tears in college. And so he's 30 years out from that, but he's still only in his early 50s. He really has no interest in arthroplasty. So this is a hard problem. And I think this is our bigger long-term goal, is if you can understand why that happens, which we don't really understand well, then you have the ability to affect that upfront. And that really has big long-term ramifications in terms of decreasing the rate of arthritis and their health and longevity as individuals, not just with their knee. So one of the studies that we're doing that's very near close to being done is the return to sport study. We know from an abundance of data that if people have normal strength, normal healthy movement patterns, and full confidence that they return in a safer fashion, the reality is most of the time people don't look for that and they just get cleared because they say, oh, you're 6 months out or you're 8 months out, we're going to let you go back. But if they do that, they're in a much safer place. And we're very fortunate here that we have the capability to do all this testing at a high level. But unfortunately, that's not the case across the country. You know, the vast majority of the people that go through ACL rehab just don't have access to lab-based testing. So the idea behind this is using simple, easily translatable and reliable things and seeing if that can correlate to a safe battery of return to sport testing. So in the upper left here is just showing single leg hop testing, essentially just how far can you hop one leg versus the other. This is strength testing for your quad. And then this is just representing patient reported outcomes. So essentially mental readiness for return. When all of those are over 90%, we call that passing their clinical criteria. Then we test them in the lab. So this is a Biodex machine, so just a fancy strength machine. This is trying to denote in the middle here our biomechanical testing, which is a little bit of a nebulous term, but think of it as essentially how they make 3D animated movies, video games, that kind of thing. So it's a 3D motion capture camera system where we're looking at them on force plates, and it gives us the ability to evaluate them very critically, better than you can with the naked eye, and then try to correlate these two together. So 50 participants prospectively enrolled. We're 1 short, so we're almost done. There's been some published on this. Shelby, one of our med students, published some stuff on this last year, but we're excited to see where this goes and see if it's something that'll be easily translatable across the country and try to get people back safer going forward. This is another one. This is relatively new. We just started this about 9 months ago. This is a squat biomechanics study. I kind of alluded to the fact that we know how people move matters. And we think after an ACL, oh gosh, we're excited for you to get back to soccer or football or whatever it is. But before that, you really have to lock in some of these more simple patterns, just walking, squatting, things like that. And it comes down to a lot of neuromuscular control. So just meaning how the muscles or the kinetic chain keep the knee in a good position in space. Okay, so that matters a lot. And that's the basis of this is if we intervene early and try to teach people how to move well in some of these simple movement patterns, will that reduce their risk of re-injury going forward? So this was in collaboration with UNO, or is in collaboration with UNO. Brian Nars, one of the PhDs there in biomechanics, and developed this really neat computer program that essentially they enroll prospectively again. We start to test them and intervene within a couple weeks of surgery. They're given a squat program that's initially very simple, and then after that can increase in complexity. And you can see here, so this is just one of the participants. This is our lab just across the street. 1 foot on each force plate. She's looking at the squat program here. And this is the output. So it starts out very simply just in terms of just saying, doing a double leg squat down and up. And then this bar in the middle is showing how far you're weighted one side or the other. And then you can increase the complexity over time as far as the task. And you can also increase the data that you're seeing back. So how much are you in forefoot, rear foot, side to side, et cetera. We'll test them multiple points over the course of their recovery and then put them through a similar return to sport battery as they get close to 9 to 12 months when they'd be getting back to activities. See if they actually test better. And then the goal is obviously, hopefully they have a healthier movement pattern, which should in turn reduce their risk of re-injury. So our target is about 27 patients. We're only 4 or 5 in. We're a little bit hampered by getting the lab redesigned right now, but this should be really interesting. We're excited about this one for sure. This is a little bit different. This is a collaboration with UNL. Eric Mark Vicka is one of the engineers there. And this was the graduate thesis work of Matt McManigal, who just got his master's last month in this. And the idea is developing wearable technology that will give us real-time joint data out in the field so that you could do it on the playing field, you could do it in the gym. You don't have to be in a clinic, you don't have to be in the lab, but try to get some useful data in an athletic or some type of activity environment where it's meaningful to the people that are getting back to it, which ends up actually being surprisingly hard to do. So it gives us some sense of why Fitbit and Whoop and some of these things have millions of dollars invested to make this happen. So I'll go over it real quickly, but Matt spent just an incredible amount of time over the course of a couple of years figuring out how to do this. And it really was truly multidisciplinary. He met with the fashion department down at UNL to learn how to work with fabrics. He's using this Cricut machine, which crafters use for how to cut things. He's working with electrodes. He had to learn computer science. He's coding all this stuff himself. It really was incredible. So these are just walking through from his thesis of basically how he built this thing. You can see here how he had to lay the copper tracings. He has to glue this in. I mean, it really was very neat. And then test it and make sure that it is going to stand up to normal activity wear. You know, we want people to be able to cycle this thousands of times if they're out in the field and not have it break right away. And so this is where he ended up with. So this is the final device. It may end up not being the last iteration, but it turned out very nicely. He just joined our staff full time. We're hopeful that we'll still get funding to actually bring this thing to fruition. But we're really excited about that. Very proud of him for the work that he did. It was a tremendous amount of effort. The last one I'll talk about and then be done is ACL walk. This is probably our biggest one. This is the main crux of our work the last 5 or 6 years. And this is really looking at that long-term goal of understanding why does arthritis occur after ACLs with the hope that we can affect that going forward. We know there's this cyclical interplay between loading, mechanical movement patterns, and cartilage, but it's really not understood well exactly how that happens. So the crux of this study is to look at how people move in terms of their mechanics, the rate of physical activity, because we know that drops after surgery. That's fairly intuitive. But then also linking that to how does it affect the cartilage early? We know that years down the road, they get radiographic signs on X-ray of arthritis, but using something with MRI, you can see here, this T2 mapping. So it's a cartilage sensitive sequence that's a little bit different and more involved than just a regular MRI, where we're looking at the cartilage health early. So it's showing us essentially the trajectory of that knee over time. The goal is to understand why this is happening, but also then hopefully have an intervention going forward that could decrease the rate of arthritis. And again, I think if we accomplish anything in the years ahead, this would have the most long-term implications far and away. So this was a very involved study, both from labor on the part of the lab, but also from the patients. They had to enroll within a month of injury. Then they had to do a bunch of testing right up front. They have to wear this, the exact same activity monitor, very sexy on their hip. So it doesn't even get to go on their wrist. They have to wear it on their hip for an entire week. Test them in the lab biomechanically, MRI, blood, serum, blood at synovium. And then we test them at multiple points over the course of their recovery, test them all the way out to 18 months. So enrollment's been done for quite a while. We have a few more collections left to go here, but this data set is close to being done. I'm just going to show you what it spits out for us clinically, which was really helpful for the patients, for me in the office, and for the physical therapist. So this is some of the data we get. This is a hypothetical ACL patient named Chris Cornett that you can see Chris's motion here, his effusion over time, what his patient reported outcome scores are. They're lower than we like, considering he's 2 years out from surgery. So he still has some work to do there mentally. If you look at his strength and then what we call the rate of torque development, think of that as power and explosiveness. It's improved over time. I would highlight one of the things that we look at is their strength to body mass ratio. So basically, how strong are they given their size? We like to see that over 3.1 in terms of reducing the risk of injury. So Chris is only at 1.8, so he still has quite a ways to go in terms of strengthening. But this is not actually Chris. This was one of our real patients, but she didn't do great, as you can tell. But this is not actually Chris. So this just gives you a little bit better sense of the mechanics, what we're looking at. As I mentioned, it's kind of how animated movies and video games are made. So it's a 3D motion capture camera system. We actually just got a new system within the past few months where it's markerless. Before you had to have these radio reflective markers on. Now it's totally markerless, so we can watch how they're moving. We overlay that onto a skeleton, and then they're doing various tasks. So in the upper right, you're seeing them do a single leg squat. In the bottom right, you're seeing them do a double leg drop jump. And then they're doing that onto force plates. So then this is some of the data that it'll spit out, essentially, how are they loading the involved knee, the injured knee versus the uninjured knee. It's produced some good data already. This was an award paper just a few months ago at the National PT meeting. Eric and Mark are presenting next month on our national sports meeting on a topic that really Mark came up with completely on his own here. There have been a couple other papers here, but we're excited about this data set finishing because we have a new sports research fellow coming in. I think we will get some really good data out of this. It truly will be a treasure trove because it was prospectively collected. There's so much stuff we can do. Tyler worked on this, Austin worked on this. There's going to be a bunch of other stuff that'll come out of it. We're also really excited about the potential for this new multi-site collaboration with the Arthritis Foundation. They just came out with this about 2 weeks ago. So they're soliciting probably 3 to 5 sites across the country to look at post-traumatic arthritis prospectively. So it would be a huge multi-center study. So we'll see if we get included in that. Hopefully we will. just a huge thank you to the funding. Obviously, this work does not come cheaply. And so we're very, very grateful that we've been funded to the degree that we have up to this point. And a huge thanks to the team. I'm sure I forgot some people here, but you can see some of our own folks. I mentioned Mark, Tyler, Austin, but Liz does just an incredible job with this lab. It's been really fun. It's kind of a ragamuffin group of people from all different backgrounds, but it is a really fun group. They've worked hard. They've produced a ton. And so very grateful to be a part of it. Any questions?
Interesting. So recently AI is going to be used as prognosticating for the work and what we're looking at.
Yeah. I think and I don't honestly know the computer side of it enough, but the ability to do it without markers is huge, because before you had to have these markers where you put them on specific spots. And actually I wondered if Cook would be here, because Cook has used this for the last 2 or 3 years doing their approach hitting. But now if they can do it without markers, it's huge, because it lets you analyze things so much easier than, than doing that. So yeah, it'll be cool. So.
Awesome. Thanks, Matt.
Yep.
Exciting stuff. All right, next up, hopefully it'll download here and open up, is Dr. Maegen Wallace, another one of my partners, talking about multi-center study that we're involved with, dealing with osteogenesis imperfecta, and Dr. Esposito in the back as well, and giving a little bit of update on that.
Great, thanks. So thanks for letting me talk about our research, and really this thanks needs to start with Dr. Esposito. He started the OI multidisciplinary OI clinic here in the early 2000s, and I am just able to kind of take over the reins and enjoy having all this patient data. So I'm just going to start with a little bit about our multidisciplinary OI team. So you can see it's quite a list of people. Obviously orthopedic surgery and genetics and our metabolic team are kind of the core, but then we also have amazing occupational therapists, physical therapists, pain management, social work, the whole gamut, looking across that. And over the past couple of years, we've been able to add more and more specialists as we start looking at these patients not outside of just their bone issues. So realizing that there's a whole bunch of GI issues that the patients have. So now we have a gastroenterologist who comes to clinic. So we're able to really provide multidisciplinary care. And then all these stars are places where we have patients that come here for their care. So we see patients from between 40 and 44 states every year. And pre-COVID, 7 countries, although last clinic, we just had a patient come from the Dominican again. So we're starting to see that come back after COVID. And then these are just some pictures of some of the amazing patients that and families that put their trust in coming here for their care. So in terms of research funding, we became a site for this Brittle Bone Disorders Consortium in around 2014, 2015. And this is an NIH funded study. You can see we're actually in the second of 5-year cycle. So we're going through years 6 through 10 now. Across all the sites, it's about $1.4 million that are given towards mostly looking at longitudinal data. So the Brittle Bone Disorders Consortium is a part of the Rare Diseases Clinical Research Network. The actual BBDC started in 2014. Currently, there's 14 sites. Most of them are in the US. There's a site in Canada, and then there's also one site in Europe. The main goals of the study are looking at longitudinal trial. So the whole consortium goal is to enroll 1,000 patients. Earlier this week, we had a PI call, and we're currently up to 958 patients enrolled total. And our site has approximately 110 patients that were enrolled in the first 5 years. Now coming out of COVID, everybody was kind of on a hold with enrolling. So in the last few months, we're starting to enroll patients again. And so we've got a few new patients that we've enrolled just in the past few months. Currently, we're in year 7 and actively enrolling subjects. And then through the BBDC, they've been able to then expand and have kind of pilot projects. So I know this is kind of small, but you can see there's actually 8 active studies within this consortium. Some of them are looking at quality of life from the patient perspective. There was a study looking at collagen peptides and urinary biomarkers in patients. There's a big push with actually dental things. So there's a lot of issues with if patients have dentinogenesis imperfecta, they have issues with their teeth. But outside of that, they also have issues with the shape of the face and the jaw. And so they have a lot of problems with malocclusion, which then contribute to dietary issues, which then contribute to lack of vitamin D. And you get into that cycle as well. There's a subsection of the study looking at pregnancy. So it's not just kids that are in this trial, it's adults as well. So they've been able to publish some things on pregnancy. And then looking at some other new drugs as well. And then one big push in this second 5-year cycle is looking at psychosocial needs. So they're actually doing like quite lengthy interviews with patients that are willing to do interviews, just looking at pain and other psychosocial issues, medical trauma, and those kinds of things through the lifespan, which has been really interesting. And then a study that they're just now got approved, and they just actually had their site initiation visit before, was actually looking at Invisalign, so the clear aligners, look and seeing if those can actually help change and improve malocclusion in patients with OI. So from the consortium itself, there are actually 38 publications. So it's a pretty active consortium. There's several other manuscripts in progress. I became the PI at our site in 2017. And so personally, just from being a part of the consortium, I have been able to have a publication from that. And then the nice part about being a part of a big consortium like this is that if there's anything that any of us want to look at, it's easy to obtain the data. So it's a simple form that any of the PIs can fill out and obtain all the data on all the subjects, but we also have full access to any of our own data. So that we've collected just through the study as well. Every year with OI, we celebrate awareness. So this was our clinic where we call it Wishbone Day, and yellow is the color that we wear. So this is the patient group of patients and parents that came the day in clinic this year that when we celebrated that. And then we're now a site for an industry sponsored trial. So as an orthopedic surgeon, I never thought I would be involved in a drug trial, but here we are. So when you have a large patient cohort and it's a rare disease and there's some exciting things, sometimes you do things that you didn't think you would do. So this new drug is from Mario Biopharma. It's called Setrusumab. It's an anti-sclerostin antibody. They've already done an adult study that's been published, and they had a dose-dependent, they found dose-dependent bone building activity on DEXA and a reduced fracture burden in adults. And so now they're starting the phase 2 or 2B trials for children. So the first wave will be just finding the correct dose for those patients. And then after the dose is determined, then the phase 3 trial will be an extension of the 2B trial. And so our site initiation visit is scheduled in August for this. And hopefully shortly after that, we'll be able to enroll our first patient. It's quite extensive. It's monthly infusions, whereas currently with bisphosphonates, most patients are doing every 10 weeks to 3 to 6 month infusions. So monthly infusions, and they have to come on site each month for that. So it's quite an extensive study. And then because of that strong base of patients that Dr. Esposito has built up over time, this is just a small list of current projects that I have going on, some of which are funded and some aren't. Children's has a Children's Health Research Institute, so I was able to get a grant and get some pretty amazing equipment. I don't know how many of you have ever heard of bod pod, but it's a machine that you get into and it gives you a ton of information about body composition, so percent body fat and lean muscle mass. So I think we've currently enrolled between 20 and 25 patients and just looking at body mass, because we've noticed that especially as the children with more severe OI, as they get older, they can't move their bodies as much because they break, but then they tend to gain a lot of weight in kind of pre-puberty and into puberty, which when they have small bones that are very brittle, contributes to more issues as well. So just another thing that we're looking at as well. So it's kind of where we are with OI research, lots of exciting things going on. So thanks for allowing me to share.
Well, just kind of thinking back to the days when you started with the ratio, made me wonder, where's the ratio now? Ratio bodies in industry, doing private research, medical director of seems to change companies with new products. It's kind of the metabolic bone type guy behind this. Yeah. Yeah, Bruce Bueller asked this. He said, you want to do any brittle bone disease? There's this guy that wants to come from Canada. I said, what's that mean? So and suddenly it just happened. One thing I want to comment on it as an academic institution, it's so nice. What Maegen left out is I kind of randomly collected data, in clinical stuff, and which created a lot of confusion. So with Matt here coordinating things, it's so much better to start out up front, plan in mind, and know which direction you're going. It just makes it much better. And the whole idea of being an academic is to make things behind you be better than you. Don't be too modest.
So I will bring it home. I know Dr. Garvin gave me strict instructions to stay on time. So I had about 10 minutes, I think, but I'll go through this quick. There were two different projects I could give. I will just give an update on one that's a little bit further along of recent funding. Here are just some of the disclosures, and we'll talk about this grant, which was my first NIH funding, which was cool. And it's just getting started. So I think this is for the spine guys because they've been sitting through everything without any excitement. So I think everybody knows, the historical treatment for kids with curves like this would be something like this. And that's just what we've done. But in peds, what really started a long time ago with Dr. Blount, but has gone on from then and gotten much more popular is this idea of guiding growth or harnessing growth using pretty simple implants. So the idea is if you can slow down the growth on one side of a deformed limb and allow the other side to grow, doing something very small, you can get some pretty amazing corrections. And so people have, over the past probably decade, have said, well, if it works so good in the legs and arms, why can't we do that in the spine? And so people trying to avoid the fusion are looking at these things called vertebral tethers or flexible tethers to try doing the same thing to decrease the growth on one side of the spine and allow increased growth on the other side of the spine. But what has happened is it doesn't seem to work quite as predictably in the spine as it does in the limbs. And so what's been shown in the literature is that it does work in some kids, but in other kids, they go through the whole tethering procedure and then end up with a spine fusion anyways. So there are a whole lot of unknowns with this. And what tends to happen in pediatrics, maybe more so than in other areas, are people just start doing surgeries on kids before we actually really know who best would benefit from that. So our grant was really to try understanding the relationship between tether tension, intravertebral disc pressure, vertebral growth, and the ultimate curve correction. And one of the kind of selling points, or I think kind of the sexy point that got us to get funded was we have a spine deformity model in a large animal, which other people don't. And this was something that I got involved with a long time ago while I was at the University of Wisconsin. It's one of those crazy kind of science stories, discoveries. The animal science department there runs a pig herd. They teach undergrads how to raise pigs. And one of the student groups forgot to add some stuff to the mix, their diet mix. And then all of a sudden they started having pigs with these spine deformities. And so then they repeated it, and sure enough, they could reproduce. When you altered the maternal diet, you could create piglets that had big humps. And so we published on this in 2018. I just wrote the numbers down there. So 2013 is when I heard about all this, and we got some little grant funding, and then we worked on this project, and it was finally published in 2018. And we kind of validated that, yeah, these curves do look like they're actually progressive. And, you know, they do kind of look like Schurman's kyphosis. We tried to characterize different things and it's reasonable. I think it's a reasonable model for kyphosis. So the idea of our study, and this is one of the things that I've thought about with the vertebral tethering is it's definitely different than in the limbs. And one of the key fundamental things is the Haider-Volkmann principle or law, however you want to say it, that the growth plate grows slower under compression or compressive loads than it does under tension, or grows faster under tension. And so you're able to get guided growth to work by asymmetrically compressing one side of the growth plate, which allows the other side to grow. And so some of the assumptions that I've had in this is thinking that a deformed spine would likely have increased disc pressure compared to a normal straight spine. That as you increase tension across the tether, unlike the knee or the ankle, that this is going to increase your disc pressure, and discs are designed to distribute compressive loads. So the thought is, you know, you're going to have this increase in tether tension. We'll see if I can say this. That's going to increase your disc pressure. That's going to increase your load all the way across the end plate. And one of the things that I've wondered is, does that, when you distribute that load, do you really just inhibit growth evenly across the growth plate and not actually allow you to get differential growth modulation? And it's maybe that why it doesn't work as well. So it's kind of a complex problem to try to sort out. But when you look at kind of some of the data from previous clinical studies, what you see is you get this tremendous amount of curve correction right from the get-go. And then when you actually look at the curve correction due to growth modulation, it's pretty minimal. And this was taken from one of the clinical studies. I kind of adapted that data. So one of my hypotheses is, if you try to do this aggressive correction initially, what you do is you over tension your tether, which increases your disc pressure too much and actually decreases the ability and decreases growth rate. So you don't see the growth modulation. Hopefully that's somewhat understandable. Again, just showing you that that's what it may mean, that it might explain why we don't really see growth modulation like we see in the limbs. And so we're just now getting started. This was me having some major issues and having to try to solve this in my kitchen. But the idea of this is the first part of it is we put spine implants in. We tension them at different tensions. While we're doing that, we're measuring the disc pressure, and then also taking X-rays to look at the change in Cobb angle. And eventually we'll be looking at growth rates. So this is just we've done some of these non-survival surgeries. So this was the piglet on the operating table. That's just the X-ray. These are with our screws in. We initially were going to do this with pedicle screws, but they were too big, so we just used regular cannulated screws. This is the transducer tip within the disc space. And this is just showing again. This is it for these non-survival ones. This is where you can see the little white areas are the discs. These are the ribs that we cut to kind of get this in, and the pressure transducers inside that disc space. Again, that's what it's showing. And so what we do is we kind of tension these tethers, and you can see, as you would expect, I actually haven't even measured the differences yet. This was just done last month. You can see over time, you see a gradual reduction in the curve. And we're going to redo this. We're just in the apical 4 vertebrae here. We're actually going to skip vertebrae on the next run of this to get over the whole curve. Majority of these curves are about 8 segments in length. And then we measure the disc pressure, and you can see we kind of plowed one of the screws here. And that's one of our things, is figuring out how much tension we can actually put on these. And this is made up. This is totally falsified. Don't like tell the NIH, but basically what has happened in all these is we do see this reduction in Cobb angle, not to 0, but we do see it go down as we increase the tension. But this was really the surprising finding just early on, and it disproved one of my initial premises, is that when we actually look at the disc pressure, the kyphotic pigs actually had a lower resting disc pressure than the normal pigs, which I was not expecting. So that was kind of interesting. And then the other thing was, after a certain amount of tension, I was assuming we're tensioning, we're compressing, we're going to see the disc space, we're going to see the disc pressure go up and up and up. But what instead we see is that at a certain place, you see this drop off in pressure. And I'll see if this will play. And this may be due to this change in the shape of the disc. So if you watch the disc right there, you'll see, hopefully you don't hear me talk, it kind of sucks in, the annulus sucks in when you actually extend it, and it actually bulges out when it gets into its native state. So it's a question of, are we actually decreasing the pressure with these tethers not being fixed angle devices? So it's not like you have 4 screws and a rod fix that you're compressing. This tension allows them to actually open up in the front, which I was not expecting. So it's kind of interesting. The other thing, this could be a technical issue, and I don't know if you can see right there is the hole from when we put that transducer in. And I don't know if we're changing the geometry of the disc, and it just opens up the annulus and lets air in, and that's why we see the decrease in pressure. Could be either of those, but it's really, really interesting finding. So the other things that we're going to be doing, and this is just showing a labeling of the growth plate of the spine. So the pig spine is a little different than the adult here, or than a human. Here's the disc. They do have an actual bony epiphysis, and this is the growth plate. And so what we do is we give 2 different bone labels at different times. And by knowing the time between when this is alizarin red and oxytetracycline are given, we can measure the distance, and then obviously we know the rate at how fast that vertebral body is growing. So as we move forward and do this in recovery animals, we're going to be seeing what effect that disc change and tension has on the actual growth. So we're coming up next week. Yeah, I think 10 days. We'll actually be doing some more, some both non-recovery and actual recovery surgeries. And then the second part of this, we'll be looking at, and this gets into a whole other kind of area that I've focused on, is we've been able to show, and my old partner in Wisconsin did a fair amount of this, that if you resect the periosteum, you can accelerate growth and get things to grow faster. So we kind of did this idea of accelerating growth plus putting, actually he did it, I just got roped in at the end, of resecting, getting the growth to go faster, but then doing the guided growth, and you see a more rapid correction. And so the second aim of this project is to say, okay, if we do correct these pigs, can we correct them faster by incorporating a periosteal resection of the vertebral body, which nobody's looked at yet. So I will end that on that one.
Thank you.
Cool.
I wondered about is, I don't know how, we call it this space, but it's not really a space, it's a structure. We measure pressure certainly in all areas of the disc.
Yeah.
One sensor, so it makes you wonder, do you measure tension in the tissue, like annulus interposterior? You somehow measure the force seen by the in-plate bone, which is probably what really matters for growth, because it's the base itself. So I don't know what's been looked at as far as how to measure.
Yeah. That is the, it's funny that is the, I don't want to say the holy grail, but it's where the engineers and other people who have tried to do this like butt heads, because there are issues for sure. I think there's issues trying to measure it that way, but at the converse of it, I think that's the best way we have. And it was one with Paul Andersen, it was one of the things that he would always talk about. The second you put something in there, you've changed the mechanical environment completely, which is true. But I think folks have shown that it's pretty reasonable. I think to know, I think it's given us some value. Is that the exact value? I don't know, but I think it's very reasonable to measure changes. But I agree. Obviously, the pulposus is going to be different than the annulus for sure.
You forgot to say, and you said that to me before, that what you're controlling and measuring is the tension in the wire, the force.
Yes.
That's the correct force, the tension inside. It's good.
Thank you. Well, we're pretty close, but pictures are going to be right here, right now. Okay, is everybody ready?
And then resume share.
Oh, you still share. Now you have to share again.
Oh.
Yeah,
Here.
you stop.
Oh, it's-
Sorry, it's okay.
Ready? Okay, welcome back. Just want to take this opportunity to tell you a little bit about our visiting professor, Dr. John Andersen. Dr. Andersen's a Michigan native, went to Ferris State University. Is he a bulldog at Ferris State? Then he went to Michigan Medical School.
Didn't think I'd hear that.
Yeah, Northwestern for orthopedics, and then developed an interest in foot and ankle and was off to Harborview to do foot and ankle fellowship. He then returned to Michigan. He's been at Grand Rapids for most of his career since then. He has been very active in education of medical students, residents, and he's co-director of the residency program and also director of the Foot and Ankle Fellowship in Michigan. He's educated over 200 foot and ankle fellows. Research-wise, he's published more than 100 scientific articles as well as chapters. So he's very well accomplished in research. And clinically, he's always ranked as one of the foot and ankle surgeons, not only regionally, nationally, but also internationally. I think it's often said that our success should be measured by the products that we produce. As you know, Dr. Swatsky trained with him, and I think that's confirmation for Dr. Andersen's success. So please join me in welcoming him as he talks this morning on a long, strange trip. Dr. Andersen.
Thanks, Kevin. First, I'd just like to thank you guys for letting me come here to be with you. I mean, this is a very, very big day for the graduating chief residents. It's not probably the biggest day of your life, but it's certainly one of the more memorable days of your life. And it's really an honor and a privilege for me to be able to come here and see your program and meet you guys and help congratulate you and send you off. And kudos, what a tremendous program. I'm so impressed by the research quality and the quantity that's coming out of this institution. And I think that's a testimony to your leadership. But this day, as I was putting together ideas for what to talk to you about, I know this day typically involves people from all specialties, and I thought I'd put you to sleep if I started talking about my project of KOH slides to diagnose fungus toenail infections. So I wanted it to be something that you could remember, and it's not about me, it's about you guys. And I think there's a lot in here for the younger residents as well. It's not just for the seniors, but it's really about the seniors. So congratulations on a job well done. It's a tremendous accomplishment to get here. We've all struggled through high school to get good grades, to get into college, and we've all struggled through college to get good grades, to hope we get into medical school, and we've all struggled to be the top of the class in medical school. And we've all been fortunate enough to get our dream job matching in orthopedics, which is one of the harder specialties to get into. and you've completed 5 grueling years. That is like mortar fire in the trenches. So your long strange trip is just beginning, but I figured my talk would kind of tailor around what a long strange trip we're all on, and I'll highlight some of the long strange aspects of my life, but I think there's a lot of corollaries and a lot of similarities between this trip that I've been on and the trip you guys are in the middle of right now. So congratulations to all 5 of you. You're all rock stars and should be congratulated for all of your efforts. It's tremendous. A day like this can't go by without acknowledgments. I think we walk on the shoulders of those that preceded us. And you got a lot of giants who've carried this program to where it is and allowed you to get to where you are. And that includes the faculty, the staff, your classmates, your own classmates, even the undergrads below you. They've helped you in so many ways. I think the apples don't fall far from the tree. So you should give your parents a big hug for what they did to get you here. They had a lot to do with this day, and they should be commended. Your family members, your mentors, your significant others, they all have to go through so much for you to get to where you are today. So just make sure you thank the people for where you are that helped you get to this point. Without these people, we'd never get to the heights that we get to. So my message to your class, I'll start with a little intro about myself. I got a few short stories that I hope don't go too long. Some things I've learned, and I'll share some parting thoughts. So as Kevin mentioned, I was born and raised in Grand Rapids, grew up on a farm, poor family, large family, didn't know we were poor. We had riches in other ways, but we never felt poor. But in hindsight, I was probably one of the poorer kids that I knew. I just didn't know it. And in Michigan, you're kind of split down the middle. You either root for Michigan State or you root for Michigan. So it's go green or go blue. My family, despite being a family of farmers, tended to root for the blue team, even though Michigan State was an agricultural school. So I always found that kind of interesting. And I was fortunate enough to match at the University of Michigan Medical School, which really opened my eyes to a different way of life and a different thought process and a different level of intensity and diversity. People from all over the world and people who are just so smart. So I thought I was pretty smart. In reality, I was very average. And my classmates at the University of Michigan really opened my eyes to all the opportunities that are out there. I was going to be a family practice doc in Lowell, where I grew up, and that was kind of my dream. And then I got to Ann Arbor and it's like, wow, there's all these different things out there. And it took me a while to figure out that orthopedics is like the coolest job in the world. And I was fortunate enough to be successful in medical school to match in orthopedics in Chicago. And now I'm really out of my wheelhouse. I'm way over the tip of my skis because small town West Michigan to Ann Arbor was a big jump. Ann Arbor to Chicago was a huge jump. I got introduced to a whole lot of things in Chicago. This was my graduating class on our graduation day, one of the most memorable days of my life. This was my chairman, Mike Schaefer. Some of the people in the audience remember Mike Schaefer, but he was just a phenomenal guy who recently passed away. And he affected me in so many ways. I didn't realize it until he passed away. And I went to his funeral, as did just about every resident that graduated Northwestern. They flew in from all over the country, and this man affected a lot of lives, and it was just a tremendous experience to see how much honor and acclaim this man received after he passed away. Chicago introduced me to street violence, which is something I'd never seen. This guy actually had 7 12-gauge slugs in his body. I got 5 of them on an AP pelvis. 2 of them were up in the kidneys. So somebody reloaded. But I say all this just because I want you all to think about where you started. We all came from a background where we all had poopy diapers at one time. And this is the youngest picture in existence of me. This is my older brother giving me my first award. Obviously, I was very happy about that. Yeah, I didn't bother to change my clothes in order to get this picture taken. Yeah, this picture, I think I was 1 year old, and it was about a year later, I lost my left eye in a traumatic accident. So, yeah, this is just a few years ago. This is my wife that I met in Chicago. And a lot of what I want to talk to you about is work-life balance. And we've hit all the highlights today already. We've talked about sleep cycles, and we've talked about joint maintenance and physical health and nutrition. Well, that all comes into work-life balance. And somehow as you get through this process and you get on your journey, one of the harder things you're going to struggle with is work-life balance, because we're all so type A and we all love our job so much. You just can't get enough of it if you love your job that much. But at some point you got to turn the spigot off, and you got to devote some time to all those other things that go into life balance. This is my first marathon I ever ran when I was a chief resident, and I was not a runner. The two guys in the picture were. I got coaxed into this. I made a foolish decision and said, yeah, I'll do it with you about 2 weeks before the race. It was one of the more miserable experiences of my life. I can look back at it and say I was overconfident and underprepared, and it cost me. I could barely walk for a week. Yeah. And I swore I'd never run another race in my life because it was just such a miserable experience. It took me a while to figure out it was my overconfidence and my underpreparation that made it the most miserable experience. I went on to the University of Washington, where I did a foot and ankle fellowship and saw all kinds of beautiful things that were brand new. Alex is very familiar with this picture. It's Harborview Hospital. Yeah, that was the view out of the office that you get to enjoy every day. Absolutely fabulous. I discovered great coffee and lots of wilderness and beautiful bridges, and certainly enjoyed the life side of the work-life balance, even though we worked very hard and I learned a lot of things. I got to do a lot of things that were very memorable. This is actually looking over the hood of Mount St. Helens 15 years after it blew. So that was the baby lava dome that was rebrewing. And to get that picture, you actually had to crawl over a cornice with somebody strapped onto your feet with a rope, because you're about 20 feet off the edge of the cliff. And who knows what that cornice is going to do when you crawl out there. But got the picture, got back as fast as possible, and lived to tell about it. Yeah, these were my mentors in Seattle. These guys changed my life. These were the guys you're going to go out and meet people like this. They were onto some things back in 1990 that were way ahead of their time. Little did I know it. I thought I was going out for the beautiful city, but I met people that changed my life. And eventually I made it back to Grand Rapids, back to my home school. My journey came right back full circle to where it began. And now I'm back in my hometown. I'm not a family practice doc. I'm an orthopedic surgeon. I'm specializing in feet and ankle, which I never thought in the world I would even consider. Wasn't even on my radar before I started my orthopedic residency. My family got bigger. My house got bigger. My expenses got bigger. It was in Grand Rapids. We're going to deep dive a little bit on foot and ankle stuff tomorrow, but it was in Grand Rapids that I started developing my own ideas of the foot and ankle. That essentially carried the torch a little bit further from what I was trained in Chicago and particularly in Seattle. And Alex is probably as adept at giving that talk as I am right now. Yeah, but I've had the distinct pleasure of sitting in front of a lot of residents and a lot of students and a lot of nursing students and MAs and medical students. And I can tell you that it's what keeps us going. The faculty that you have here are second to none. We do this because we love it. We've got something that I was never going to be an educator. I was not going into academics, but there was an infection in my head that I developed, passed on from my mentors, that just made me more inquisitive about certain things. And your mentors are infecting you with that inquisitiveness. And we hope you go on and do the same thing and move the needle a little further. So you're on this journey to expand your mind, but you got to find a way to do it where you can mix your family and your friends. And it's really not hard. If you look at some of the pictures, you'll see there's a lot of smiles, but in the midst of this journey, there's a lot of things you got to do. And these things can be stressful. You got to buy a house, you got to sell a house, you're all going to move. You got to learn things you don't know anything about. You got to learn about life insurance and disability insurance, and you got to learn about hospital administration, and you got to learn about CPT codes and the business side of medicine. You got to save for the future. You might have kids. You got to figure out how you're going to pay for your kids' college. I mean, these are all stresses in life. And then you're going to go through all that. You're going to have a coach on your kid's soccer team that's just a knucklehead, or you're going to have some partner that's just difficult, who doesn't follow his patients, or there's no end to the bumps that occur on this path. And you think they're ending after your residency, but they're just beginning. You're going to travel on numerous meetings. This one being an easy one, but a lot of them are going to take you to far away, interesting places all over the world, which what a treasure, what a privilege to be able to go out and see the far reaches of the world while we enjoy our profession and meet different cultures and meet other ways of doing things and carving a craft. Everywhere I've gone, I've learned something about my craft just by seeing how other people do it. And it makes the whole thing enjoyable and extremely educational. Yeah. There'll be opportunities to give back. This was after the Haiti earthquake. We were one of the first ones on the field, but what a privilege to be able to go to a foreign country and help put people back together who didn't have any resources. I mean, I would encourage you all to find a way to give back, to use your skill set, your knowledge base. And hopefully in the process, you'll have as much fun as I have. Yeah, my running career actually was just starting with that bad experience. So here in 2014, I ran the Berlin Marathon at a meeting in Germany. Yeah, but there's been so many adventures, so many friends, so many interactions, and so many influences that I'm in debt to and have immense gratitude for. And it's all those people I talked about. It's my wife, it's my family, it's my kids, it's my mentors, it's my administrators, that's my colleagues, my classmates who are still like some of my closest friends to this day. You guys will never lose touch with each other because you've been in the foxhole together. And 5 years in the foxhole, it's a special bond. So this is one of my runs. This was my run printout on my cell phone. And it was the day before we were going to do this in Grand Rapids. So I'm running the program, and I've got my classmate who's a spine surgeon, very, very prominent in Indianapolis, and he's going to be my guest speaker. He's going to stay at my house. He's on his way to Grand Rapids. I'm going to zip in a quick 5-mile run. I'm going to pick him up. We're going to go have a drink, and then he's going to come back to my house, and we're going to hang out and reconnect. Something went wrong on this run. You can see I either got lost or my phone got lost, but it takes an abrupt end about 3/4 of the way through. Yeah. And you've all heard Ford built tough. Fords are built tough, but those of you who have ever hit a deer know what a frightening experience that can be. It wakes you up pretty fast. Well, imagine you're the deer. Yeah, so I got hit by a Ford truck going 60 miles an hour, and that's me in the emergency room. And that's 7 years ago. And Alex remembers this because he was there. Yeah, and that's me in the rehab 2 weeks later with broken arms, broken wrist, broken skull, broken ribs, punctured lung, brain hemorrhage. You look at that list and you look at that face and you think, how does that guy live? Who knows? It's a random act of God that I'm alive. And I'm one of the few guys I know who was able to give a trauma keynote address because he was a trauma patient. Not because I spent 20 years taking trauma call, but because I was a trauma patient. And you learn a lot being a patient. And I think it actually made me a better doctor because I know all the weird things patients go through when you don't know if you're ever going to walk again, you're ever going to use your hands again, you're ever going to feel your fingers or your toes. Are you ever going to be able to pursue your dreams, your passions? And this was a guy that was running 150 miles an hour, full speed. I did 9 surgeries that day. I had a big event with a big graduation party at my house. My daughter was going to have a big party the next day. I spent that whole weekend in the ICU. And I spent the next 6 weeks in a wheelchair wondering if I was ever going to be able to do anything. And you think a lot of weird things, that the patient who is down and out, you see it from the medical side, but the patients are going through all these life balance equations. What are you going to do if you can't go back to work? Geez, I'd love to be a carpenter. I'd love to be a teacher. I want to be a salesman. What are you going to do? Yeah, which begs the question, if today was your last day, what would you do differently? Would you do different today if you knew this was your last day? And somebody's probably asked you that before, but I never thought I would ever ask that question. I was the healthiest guy I knew, but literally it was almost my last day. And for 6 weeks, I couldn't get out of a chair. Somebody had to clean me and bathe me, and I could, 2 broken hands, couldn't move. What are you going to do now? If you're not going to be an orthopedic surgeon, what are you going to do? I had to sit and think about that for a long, long time. And would you do something different? So I would challenge you all to look back and say, if you could do something different, what would it be? And if not, what would you do going forward to take advantage of your short time? Life is so short. How are you going to make today the best day of the rest of your life? And I say that often when people say, how you doing? And my answer since that truck is, today's the best day I've ever had for the rest of my life. Every day is my best day. It's another day. And look at me now, you'd never know, right? I mean, for God's sakes, it's ridiculous. Yeah, well, when I look back, there really wasn't anything I would have done differently. I was living my dream. I was that little kid with a poopy diaper thinking I was going to ride a tractor on a farm, maybe get into college, maybe go to med school. Went on a journey that I never possibly imagined, traveled all over the world, did a lot of research, and have given many speeches. None of that was anticipated. It was my journey. It just took me somewhere. But all of those steps were an opportunity to reach a new height. If anybody that's ever seen the movie The Alpinist, if you haven't seen it, this is one of the mountains in that movie. It's one of the better movies I think I've seen in quite a while, but I would encourage you all to read it, because that's a guy that lived life. And he definitely got outside of his comfort zone, maybe too much. I asked you, how are you going to change the world? Try and give back. But you all are the smartest people on planet Earth. You can change the world. It may be small, it may be large. How are you going to do it? Figure out a way to change the world, because it's not that hard to change the world and make it better. Your staff have done it. This university has done it. The faculty have done it. The research you're seeing is changing the world. It's making people better. You guys, you've done it with the research projects you've had, but you can't stop there. That means you got to grow. You got to get out of the poopy diaper, and you got to get into a clean situation. You got to keep moving forward. Moving forward means don't stand still. So this is the very first marathon I ran in 2013. This is the last marathon I ran 6 months after I got hit by a truck. One, I was disappointed, miserable experience. I was absolutely frustrated with my time. The other was the best day of my life. The last one took twice as long as the first one. My expectations were a little different. But to be able to run a marathon with my 5 kids after being in a wheelchair, not knowing if I was ever going to walk, was just a tremendous experience. It's more of a resetting of your expectations and your guidelines, but I was so happy to be able to do it again. It was just a treat. Expand the mind. I've spent a lot of time learning my craft, foot and ankle surgery. Sometimes a bunion surgery is a little mundane and routine for me now. I've got to find other things to get outside my comfort zone. Golf is one of those things. I can still play golf. Anybody that's played knows it's way tougher than orthopedics. So I try to spend as much time as I can now, taking iron and greens every day. But I still haven't stopped learning. Leave a legacy. That may be your kids, that may be your institution, that may be your community, but do something significant and make the world a better place. And if you do so, you're going to change history. This man changed history. This is Ted Hansen, who, from Harborview, kind of built that hospital from the ground up when it was just a low-level county hospital that nobody wanted to work at. And he started doing things at Harborview Hospital that just made sense to him. And he was criticized for years for doing things like plating open fractures and rodding femurs immediately and taking people straight to the OR and amputating mangled legs. All of those things got him reported to the state board and to the authorities, but it made sense to him. Yeah, he then did the same thing in the foot. He stopped taking trauma call. He transitioned to the foot and he started doing things in the foot that had never been done. And now he's got third and fourth generation descendants of things that he taught me and I've taught Alex, and Alex is now teaching you guys. And each step along the way, we're trying to refine these concepts and principles. And that's now a baton that's getting passed to you. You have the knowledge, the skill set. You're in a unique spot. You know a lot of things that a lot of people don't know. You've got a responsibility with that to push the needle a little bit further. So this opportunity you've been given is really just the beginning. You're in the top of the first inning. Your game has not really even started yet. There's a whole world of experiences out there waiting for you. And this is such an early stage of the game that you just got to wake up every day saying, last game didn't count. It's first bat and we got to win this game. So I'll talk a little bit about the Schwatsky zone. Schwatsky's famous in Grand Rapids, as you can imagine. Yeah. So he came on my service in his third year. So I was early in my recovery. And it was summertime and I had a fellow who was working with me. And my daughter had just graduated at the University of Michigan, and Mike Bloomberg was the keynote address speaker. And he was telling the story of in his 40s, he's married, he's got 3 kids, he's got a secure job, but it's not the job he really dreamt of doing. He always wanted to break out on his own and do something big, but he was always afraid to get out of the comfort zone and give up his guaranteed salary because he was worried about losing his income and having to move out of his condominium, and who knows what could happen. Well, then the economy went down, he gets fired, and he wrestled with this idea. I should just take another job. No, 30 years I've been wanting to do something on my own. This is my chance. This is my chance to do it. So he did it. And it just happened to be when the internet was coming of age, and he starts a data collection company in the financial services industry and becomes one of the 10 richest guys in the world. Now he's like Warren Buffett. He's trying to figure out how to give his money away and what he can do to use it. But his point was, if I didn't step outside my comfort zone when that happened, Bloomberg News wouldn't exist. Yeah. And his challenge is the same one I challenge my kids to, and the same challenge I challenge you guys to, is you got to figure a way every day to get outside your comfort zone. Find the things that make you the most afraid. You're most scared of failing. You're afraid you can't tackle. Those are the things that make you feel most alive. And if you continually back away from those things, you're giving up on opportunity. So you've got to just continue to push yourself into things that you know are hard, going to be hard. For me, running marathons was one of those things. I started running marathons because fixing bunions became too easy for me. And running marathons were never easy. Yeah, so I would go out and run because it pushed me into an awkward, uncomfortable zone. And I'm telling Schwatsky this story while we're doing a real complicated foot reconstruction, and I'm putting screws into the subtalar joint. And I'm outlining all these angles, and he's firing the screw, and I'm not letting him use C-arm or cannulation. And I'm drawing all the pictures out for him. And time was of the essence because we had 10 cases that day. So I'm like, Schwatsky, come on. You got it. Come on, keep up. And he visibly starts sweating while I'm telling the story of Michael Bloomberg's get out of your comfort zone. And I'm like, Schwatsky, look at you, man. The nurse comes over and dabs his forehead. And I'm like, you're in that zone right now. And he's like, Dr. Andersen, I am so in that zone. I am so uncomfortable right now. And I want to live here for the rest of my life. I want to stay in this zone. So for the next 3 months, it was like, all right, we got to go get in that zone somehow. So he would go running with me when I was in my recovery. And now it lives in infamy as the Schwatsky zone. Every third-year resident comes through and they get a little sweaty when things get tight. And I talk about the Schwatsky zone, and our current residents, half of them don't even know who Schwatsky is, but he's this god that sits on a pedestal because I usually name things after things the residents do that are really silly. Like they forget to staple a wound, or they put a clamp on a thigh, or they do something that's like they turn their brain off just for a second. And there are very few residents that get through the program with something that's notable and memorable. And Schwatsky was one of the few that managed to do that. So you guys are lucky to have this guy. Yeah, and he hasn't changed a bit. So I'm going to wrap it up. Your journey is going to take you around the world and back through time, just like mine, just like all the other faculty. Yours is just beginning. Be grateful for what you got. This is a treat. I had mine taken away from me briefly. I couldn't imagine how fortunate I was just to experience the things I experienced before it got taken away from me. What an honor, what a privilege. And the days where you got that cranky patient or administrator just giving you grief and you just want to call it in and become a farmer, you got to go back to where you started and remember the poopy diaper guy that just couldn't wait to get into medical school. Because you're going to have those days, but you just got to remember how bad you wanted it and what a privilege it is to do it. Stay humble. Don't ever get so full of yourself that you can't get beaten down. It happens every day. It happens on a regular basis in this field. You're going to have patience. You're going to have outcomes. There are things that are going to happen that are going to humble you every day. So stay humble, but enjoy the small things and treasure the journey. Now, it doesn't matter where you end up. It's just, how do you get there? Maintain your integrity. You can't get that back once you give it up. Stay in your wheelhouse, stay in your strike zone, but get outside the strike zone enough to push the envelope and make yourself uncomfortable. You're going to get some losses. You got to move on from those. You're going to get some base hits. Take them and move on and step up to the plate and do it again, because every next day is a new inning. And if you continue to play like it's your first inning, you're going to do great things. Aim high, never settle. Don't stop trying. So I congratulate the graduates. I congratulate all the residents that got into this program, because it's a phenomenal program. The graduates who are moving on, I wish you good luck and Godspeed. And I hope to see you along the way. Thank you.
Excellent, great journey, and I'm sure there's some questions.
Yeah.
Alex, how much were you sweating that day? Is that a change of scrubs? Sweats.
Yeah, he's also one of those guys that in between cases would drop and do 20 push-ups just to get a little
You
exercise.
can still do that.
Yeah, with one hand.
Perhaps. Or slapping his back in between,
So
hand behind his back.
he was a unique resident.
So much what you said is so true. That's good.
Okay.
Be around this afternoon. I'm sure people will have some personal questions to ask you about. Thank you again. Well, they're loading up Coach John Cook's slides. Just a little introduction about Coach Cook. He's been in Nebraska quite a while, and you probably think that he's a Nebraskan, but he actually grew up in Chula Vista, California, just south of San Diego. And it was pretty clear early on that he was an exceptional athlete. He was quarterback of their football team, and also one of the strong forwards, a 6'3" forward on the basketball team. And apparently he and his brother maybe didn't dominate San Diego, but he played a lot of good high school basketball there.
to the extent where he was recruited to the University of San Diego on a scholarship. And at that time, San Diego had just become a Division I school. So it just reflects on the talent that Coach Cook had and was recognized by the coaches there in San Diego. As he finished up his career as an athlete, he was really thinking about coaching, and he started out coaching some of the high school football teams in the San Diego area. But he wanted to teach as well, and perhaps there was a little monetary incentive there because teachers and coaches made a lot more than just the isolated coaches. The challenge was the coaching job that he took wasn't coaching high school football or basketball, but it was coaching girls volleyball. He and his brother played some beach volleyball with a couple of other friends of theirs. I believe it was the Ashworth brothers, started the golf industry clothing line later. And of course, as you can imagine, he quickly developed a successful basketball team. And I think they had a streak where they had 90 consecutive victories. And when you're a great volleyball coach in Southern California, you might get noted by somebody like Terry Pettit. And it wasn't long before he was offered a job to come to Nebraska in late 1980s. So he started out as an assistant here in 1988. They had some very good seasons and was lured to Wisconsin because then he could be a head coach, and brought Wisconsin up to a very competitive team, played the regionals in Lincoln against Nebraska. And although Wisconsin got beat, when he met with Coach Pettit later, he was offered the job with the thought that he'd become the next head coach in 2000, which he did. There's no question he's been extremely successful. He's had 4 national championships, I believe 10 Final Fours, 7 of which they played in the finals. So he's got a better than 50% average in finals, which is amazing just to win one, but to have such an amazing average. He's had 60 All-Americans, 19 academic All-Americans, twice voted the American Volleyball Coaches Association Coach of the Year, and in 2017 was elected into the Volleyball Coaches Hall of Fame. What a record. But when asked about his record and things, he quickly deflects the personal success and said, this is about the Nebraska volleyball program, not about one of us. And not only is he an outstanding coach, but he's in my work with him, he's an outstanding person. And it's really a thrill to have him here talk to us about this dream like a champion. I think it fits well with our other visiting professors talk as well. So Coach, we're excited and thank you.
Okay, are we dialed up here for this? Well, it's an honor to be here. I'm trying to figure out how I got into this. I'm a volleyball coach, but I wore white today because maybe I'll be a doctor of volleyball at the end of this. Dr. Andersen, that was a great speech. And in preparation for today, I called some doctor friends of mine. I asked them who spoke at your graduation. They couldn't remember. I asked my 2 kids who graduated from Nebraska, who spoke at your graduation. They couldn't remember. So I know I'm going to remember your talk, and I think you're going to remember mine once we go through it, because I see a lot of parallels as we go through this that I think kind of similar journeys here. But I'm going to bring it to you from a coach's perspective. And I like to communicate. I have to communicate with college kids. Their attention spans aren't very long. They're not very good listeners. We do a lot of it visually through video, sending messages. I use other things in their world that help them connect. So I'm going to do some of that with you. But again, when Dr. Garvin asked me to do this, I thought, okay, what's he thinking here? Maybe because, you know, I was a first-gen graduate at Nebraska. Maybe because my kids graduated from there. Maybe he wants an NIL deal. Nebraska volleyball. I know he doesn't want to play golf with me because I'm not very good. Or maybe, and then he sticks me right before lunch. So this is always the speaker's nightmares go right, you know, lead up to lunch hour. And I know you guys have been grinding here today, but I have a tremendous amount of respect for what you guys accomplished. You guys have been going 13 years grinding on this. And, in volleyball and coaching, we call that the 1,000-hour rule or 10,000-hour rule. To be a great athlete, and there's a book about it. 10,000 hours is what you got to do. And I'm sure you guys are on that path and on that journey. And then where's Dr. Roedel? Okay, you remember me?
I do.
Where'd we meet?
We met in the OR.
Yeah. OR. And then I remember you came to my room, and checked on me and, because I asked Dr. Garvin right away, I said, this is the same guy, right? So we met before, and I'll talk a little bit about that as well. This is a book that I wrote, and again, as Dr. Garvin mentioned, I grew up in Chula Vista, California. If you watch Narcos, you'll know where Chula Vista is. Right in the border. I grew up, my mom was 17 and my dad was 18 when I was born. College was never an option. So I want to share this with you because I want you to know why I coach and why I wanted to be a coach. And a coach took me aside and said, I think you can go play college sports. And I said, what do I have to do? He said, well, you got to pass the SAT and you got to get recruited. So I was getting recruited and I failed the English version of the SAT test. So I thought I was a dummy. And an English teacher took me aside and tutored me for the whole rest of my senior year. And the last shot in May, when I could take the SAT test, I passed it. And I made a vow to myself, someday I'm going to prove to people I'm not a dummy. And this was a book that I wrote. We actually had a second edition on it. And it's a lot about the experiences of coaching and at Nebraska. And again, one of my mentors was Coach Osborne. He's written 3 books. And I talked to him about doing this because people kept telling me, you need to write a book and put some of this down. And so I'm very proud of this. And this is why this is such a, I have so much respect for you guys. I mean, it's just like you just hit the Super Bowl field goal. You just hit the NBA final shot. You just spiked the final to win a national championship in volleyball. I mean, it's a hell of an accomplishment. And like Dr. Andersen said, I hope you appreciate it, enjoy it. And, like Dr. Garvin said, we've won a lot of Final Fours and national championship matches. All I know is we just lost the last one by 3 points. That's all I remember right now, but I got to go back and think about some wins after hearing Dr. Andersen talk. So I don't know how many of you know anything about Nebraska volleyball.
Nebraska Volleyball, a program built on ultimate trust, sacrifice, and relentless pursuit of greatness. A proud fan base that has built an NCAA women's record sellout streak for 20 years and counting. A tradition-rich history with 5 national championships and 34 conference titles. A nation-leading 98 all-time AVCA All-American Award winners. A program that has produced 9 Olympians and 6 Olympic medalists. At Nebraska, volleyball is more than just a game. It is a passion. It represents what trust, commitment, and love can achieve. At Nebraska, we are family, the coaches, the players, and the fans. We are in this together. At Nebraska, champions are formed in the summer and crowned in the winter. At Nebraska, big dreams become big realities through hard work, sacrifice, and trust. There is no place like Nebraska.
All right, a little bit about my world in Nebraska volleyball, and that's a big deal here. So I'm going to take you kind of through my journey, and if I have a second life, I want to be an orthopedic surgeon. And after you hear some of this, you're going to know why. So on one of my volleyball trips to South Lake Tahoe, we went up there and played. I was dating my wife at the time. We went up, played in the beach tournament, and then we decided to spend a few days in Tahoe and hike. Well, this article is about me. I went off this cliff right here, this waterfall. Went down 100 feet. This was, we had hiked all day in a place called Desolation Wilderness. And it's up above this Cascade Lake, above these falls. It's a very remote, tough area. We came back, we were hanging out at the top of these falls, and I won't go into detail, I'll call it a rock climbing accident, but I was being stupid. And we hadn't eaten all day, and I just lost consciousness and fell over backwards and went off that waterfall. And you talked about like miracles, okay? And so I ended up at the bottom, I'm hanging off a rock. My brother, my future wife and his girlfriend were on top. He ran down, found me. I was laying upside down. I was still conscious. And he goes, "You okay?" And I'm like, "Okay, here's what happened." I go, "I broke some teeth and I think I dislocated my hip." So, but I'm hanging upside down, so I'm bleeding out of my mouth. And so he gets underneath me, and for 3 hours, he had to support me. And if you ever seen athletes cramp, he started cramping, okay? And that'll be an important part here in a second. So part of this, what happens here is my wife and his girlfriend are trying to find me, and they're calling my name because they're in shock. And ironically, there's a guy coming down where we had just come from named John, because they're screaming my name. They're trying to find me down there. He goes, "Up here." So they run back up thinking I crawled back up to the top of these falls. Well, this guy happened to be a respiratory therapist at Barton Hospital in South Lake Tahoe. So he came down. This is now getting dark. He builds a fire and he sends my wife to run down to this lake right here. And you have to go all the way around the lake to get to the road. So we have no cell phones. There's no cell phones back then. So she starts running and there's a guy fishing right at the bottom of this lake. He's in a 14-foot aluminum boat. And she says, "Hey, my boyfriend's fallen. We need to get help." Happens to be a sheriff. So I've got a guy building a fire, keeping us warm, a sheriff fishing. He radios in. And again, it took 3 hours. They got 24 guys up there, put me in one of those basket things, and started still hauling me down because it was still really steep there. They get me down to the lake and they put me in the 14-foot aluminum boat that this sheriff was fishing in. And they get in, and I can remember it like it was yesterday. He's in my face. He's been drinking. I can smell it. And he goes, and it's just pitch black now. And I go, "Where are you taking me?" He goes, "We're going to go to the other side. There's an ambulance waiting." And I said, "You sure you know where you're going?" He goes, "Hey, if we tip this thing over and crash, you're going straight to the bottom. So don't worry about it anyway." I'm trapped in this battle. He gets me out of the ambulance and I get into South Lake Tahoe Hospital. And this is the doctor who's on call. Does anybody know who this is? This is Dr. Stedman. And if you guys have done your history on orthopedics, he's one of the top guys ever because he's dealt with a lot of the USA ski team. And he was doing his work at Tahoe at the time. Now he has a Stedman clinic in Vail. But he was ahead of his time back then because he was very aggressive on how to rehab patients. So I think when he started, maybe, and again, maybe you guys, the older doctors in here would know more, but he was ahead of his time and really pushed these skiers in rehab right after surgery, get them up, get them going. And I think had a lot of impact on orthopedic surgeons. What was great was this guy happened to be my doctor. And so I'm going to tell you this part of it because this is I remember Dr. Roedel, okay? And I got my hip done here and he was there. Dr. Stedman, I was coaching football at the time, played for Bear Bryant. If you've seen the movie, The Junction Boys, he went through that. And then his third year, he quit because he wanted to be an orthopedic surgeon. And he knew football wasn't going to get him there. But he went through The Junction Boys with Paul Bear Bryant. It was really tough. Like half of them couldn't even make it through. So we talked football every day. And this is me, 9 weeks in traction. They drilled, I'd broken my femur in 9 places, compound fractured it, broke my jaw, separated my shoulder. This is me for 9 weeks, Dr. Andersen, in traction. You can see how they rigged all this up. And every day he would wheel me outside at South Lake Tahoe. This is in July and August, September. And so I could sit in the sun. And then he did something that I'm not sure you guys get this in medical training. There was a skier named Pete Patterson, who was one of the top downhill racers in the world at that time. He had broken his femur and he had come back to see Dr. Stedman for a final checkup and turn him loose to go start skiing and training. He sent, and I was at the bottom when Dr. Stedman told me, he said, we're pretty good traction. It looks like it's healing pretty good. This is after 3 weeks. He goes, I'm gonna leave you there. And I'm like, okay, well, how long am I gonna be here for? He goes, at least another 6 weeks. And I mean, I wanted to end it right there. There's no way I can do this for 6 more weeks. Pete Patterson comes in later that afternoon and he sits down with me and he says, hey, I've been through this. He says, here's what you got to do. You got to start reading. We're going to get you some music and we're going to start lifting weights. So he brought in weights for me so I could lift in this bed and work out every day. And then the other part of this miracle, food processors that just come out. And I'm going to share this with you because hospital food sucks. They're feeding me Jell-O every day. And I'm losing weight. My mom buys a food processor, moves up to Tahoe, and starts making meals and pumping vitamins in them and grinding them up because my mouth was wired shut from broken jaw. All I could eat was what was through my teeth. So there was my mom started nutrition rehab in this country. But I really believe it helped me heal really, really well. So very, very lucky. And this is my first experience with orthopedic surgery and Dr. Stedman. And anyway, just so lucky to have a guy like that. So again, as Dr. Andersen said, you never know where you're going to make an impact on somebody's life. Think outside the box. By him, Pete Patterson probably saved me mentally to get through that. And those are the little things that make a big difference in people's lives. My next adventure, after I came here as an assistant, I got hired as assistant coach of the USA men's volleyball team. And this is the 1992 Barcelona Olympic team. Several of these guys at the time, they were playing overseas for 9 months, making millions of dollars playing volleyball. And then they would come back for 3 months and be the USA team in the summer. We went all over the world. We went to Russia, China, Cuba. This is back in the early 90s, all over Europe playing. This team, we won the bronze medal. But here was the challenge. When they hired me, they said, hey, John, you're going to be assistant coach. You're in charge of block and defense, and you're in charge of our strength training program. We were based in San Diego at the time, so we had a place to train. And I knew nothing about how to train these guys, men. I coached women. I had a great experience here in Nebraska with Husker Power, with Boyd Epley and those guys, but this is a whole different ballgame. And probably half these guys were over 30 years old, still playing at the highest level in the world, but they were beat up. They had all kinds of issues. So I'm like, how the heck am I going to do this? I'm coming from a women's program. These guys are going to think, who the hell's this guy? So I found this guy in San Diego, Peter Goskew. And Peter Goskew was the youngest Marine ever to become a major in the history of the Marines. He was in Vietnam, he got blown up. He was in a hospital, rehabbing in an Army hospital or a Marine hospital, however they call those, for a year. And nobody was helping him. So he decided on his own, how the heck am I going to rehab myself so I can live a normal life? So he started studying anatomy. He started studying rehab. I think he studied Buddha principles or the yogis and those types of things. He just started doing everything he could and he rehabbed himself back. So he got this method of potential rehabilitation. And then he started working with golfers in San Diego. He was in San Diego and these wealthy guys and Jace, you're going to Torrey Pines, right? Where's Jace? Torrey Pines, right? San Diego. He was right there. I know right where you're going. I know some doctors that were there when I was out there coaching. But he was helping a lot of the rich people in that area, Rancho Santa Fe wives, so they could play better golf. Well, then Jack Nicklaus hurt his back right before a big tournament, called Pete. Pete flew out wherever this tournament was, rehabbed him for a couple of days. Jack Nicklaus went and won the tournament. He became famous. I think he's written 5 books. It's called the Egoscue Method. But this is what I learned from him in coaching, and I want to impress upon you guys as doctors. you guys are trained to come in. I broke my leg. You're trained to come in and fix it. But I see athletes every day. Their knee hurts. They have tendonitis. Their ankle hurts. Their back is sore all the time. What's causing that? Okay. And then he looks at everything as what's the cause? You know, those are the symptoms, but what's the cause? And the best doctors I've been around will look at that instead of like, okay, we're just going to fix it and shoot it up. But doc, why is her back hurt? What's causing it? Is it the shoes? Is it how we're training? Is it the surface we're on? So think about, you know, what's the cause of a problem, and always look at it that way. And this guy's, you know, he's helped hundreds of athletes, thousands of athletes, elite athletes, all from all walks of life. He's retired now. His institute's still going. It's based in San Diego. They have clinics all over the United States, all over the world. And he now consults with San Francisco 49ers. And one of his prized pupils that he trains is John Lynch, who played for the Denver Broncos. And he's the general manager of the 49ers right now. And if you watch John Lynch play, they'll tell you, if you talk to NFL guys, he's one of the hardest hitters ever in the history of NFL football. Because Pete trained that guy, and I actually worked out with him at Torrey Pines High School. Again, Jace, right where you're going, right? It's like 3 miles down the road. I saw what he did. He did unconventional training methods, very little weight. It was all just kind of like think of a jungle gym training these pro athletes. So again, thinking outside the box, thinking of the symptoms. And then there's Dr. Garvin. And as probably 3 years ago, I called and got an appointment with him because the orthos, our team orthos in Lincoln wouldn't touch me. I need my left hip replaced or fixed. And I walked into Dr. Garvin, got an appointment with him. Took quite a while, but I walked in. He goes, I knew you'd be coming through that door someday. I go, how'd you know that? He goes, I've watched you walk at the volleyball matches. It's been getting worse, hasn't it? So again, another tremendous opportunity for me to be with what I recommended several people to him. He's world class. And what was fascinating for me was I didn't have a normal hip. And remember, the guys in Lincoln wouldn't touch me. They told me, you got to go to Omaha. And because I had a very challenging surgery, the way that my leg had healed, and femur and trochanter and all that. And he made me believe this was all going to work, and it worked great. He wasn't sure how we were going to do it. I think we had 5 hips out there you were thinking about using, and Dr. Roedel was in there, and there were some other guys, and I was just so impressed with the team, the med center, how they took care of me. It was an incredible experience to go through. So anyway, I'm very grateful for him. And again, this is why it's such an honor to be here. So I'm going to share some coaching secrets with you. I've been coaching a long time. And I think coaches at a high level are very similar to orthopedic doctors. We're type A, we go hard, we're after it, we compete. And we're on to the next battle, and we're not afraid to work hard. So, but I want to share some things like Dr. Andersen did that kind of have resonated with me over time. And these are secrets that I share with other coaches as well. First of all, attitude of gratitude. We know if you're grateful for everything, you'll be happier. And I recruit players that have been given everything. They've been told how great they are. They've never experienced failure or very little failure by the time they get to Nebraska volleyball, because we're recruiting the best of the best. And I try to get them to understand you have to be grateful for all this opportunity and all the things that you're given. And they are spoiled, I will admit it. But if I lecture them like that, they think, oh, this is my dad giving me a lecture. They tune me out. So I use Chick-fil-A. You guys know that Chick-fil-A is the #1 most profitable franchise you can own in America. And the reason is because 94% of the time you go into a Chick-fil-A, they make you feel appreciated. And I actually flew on a flight. I didn't even know what Chick-fil-A was, but when they opened in Lincoln, my players camped out at 4 a.m. to be the first ones in line. And I had flown 6 weeks earlier with a guy coming to train the work there. And I don't know if you guys go there, but they tell you it's my pleasure to serve you. But they make you feel good. They make you feel grateful. So I use this with our players, make everybody feel like when you go into a Chick-fil-A. And we're doing camps right now. This is our 10th day of camps. And about every third day, we use Chick-fil-A to feed the camper kids. They love it. They love it. And, but anyway, attitude of gratitude. And this is a hard thing to do, but I loved his picture of everybody in the team, but appreciate those nurses. I think nurses are angels and what they go through, but appreciate the people that are helping you and working with you, and use that attitude of gratitude. The second thing is, the longer I coach, the less I know. So as Dr. Garvin mentioned, my first year here, 2000, we went undefeated and won the national championship. The only 3 teams have ever done that before in the history of college volleyball. I thought, this is easy. We're going to do this every year. 21 years later, I mean, I've learned through COVID, I've learned more about coaching through the COVID thing than I did in the previous probably 19 years. But I tell myself this all the time because I want to keep learning. And I want to get better. And I think it keeps you from burning out. And it keeps you humble. And it also always keeps you to try to get better and better. So remind yourself of that. And it's a cool world when you get to go out there and learn from people. And then this thing, I think, is you guys have already figured this out, but you never know when you're making an impression on somebody. I got on a flight a year ago going to Denver I was actually going to Denver to San Diego to recruit. I get on the Denver flight. This guy sits next to me on this plane at 6:30 in the morning, and he says, "Hey, coach, you remember me?" I said, "Sorry, I don't." He goes, "I was on your first middle school boys basketball team, Francis Parker, 1982. I go, "Yeah, that was a fun team. It was one of the first teams I ever coached." And so he told me a little bit about what was going on in his life and so on. And of course, I'm 6:30 in the morning, I got to recruit for the next 12 hours when I get there. And I really didn't want to talk to him. I kind of gave him the look like, okay, just let me sleep. And he goes, "Hey, do you remember the first or the story you used to always tell us?" And I said, "No, help me with that." And he goes, "You talked about the greatest leader of the greatest civilization wanted to pass down why they were so successful. And so he had the smartest guys work on it. And they worked on it. They got it down to about 10 pages. And he said, too complicated. We got to make sure everybody can remember this generation after generation." So they got it down to one sentence. There ain't no free lunch. And I've got to instill this in our players. Nobody's going to give you anything. And same thing, you guys have this attitude. There ain't no free lunch. You got to go get it. And again, for young people, this is a hard concept for them to understand in the way they're raised now and how kids grow up. There ain't no free lunch. And then you have to have a team within a team. So I use an IndyCar as an example. This is Nebraska Volleyball's the IndyCar. I'm driving it. I've got to have this great team around me. So I've got a psychiatrist, I've got a former player, my wife, Coach Osborne, but I've got people that are helping me be the best I can be. You can't do it on your own. So surround yourself with people that are going to make you better and make you great. And the other thing that I want to kind of share in this team within a team, at some point, you're really going to need those people. And Dr. Andersen's already talked about it. And I'll tell you a quick story. 2009, we had one of the greatest seasons ever in 2008. We get to spring of 2009, I wake up one morning and it's like the world's upside down. I don't feel right. Something's wrong. They take me in. I go see our team doctor. He sends me right away to St. E's. They start checking my heart. Anyway, something wasn't right. So I went through all these tests and I started going around to see all these doctors. I saw a kidney guy. I saw a neurosurgeon. I didn't see an orthopedic, but something wasn't right. And every time I'd go talk to one of these doctors, I would say, hey, how do you handle burnout and the stress and everything? And they would go, I don't. And then I go to Coach Osborne, who was our athletic director at the time. And I said, Coach, how did you handle stress and when you were coaching and the long hours and the expectations? He goes, John, you know, I had a heart attack when I was 52. So it hit me. He sent me to Mayo Clinic. Went through all the stuff up there. I come back, you know what it was? It was stress and burnout. That's what they concluded. So I went into what's called cognitive behavior therapy. The head person of the whole country is actually in Lincoln at the university. Changed my life, found my fire again, started feeling better. But at some point, you're going to hit the wall. These indie guys hit the wall. So what's your plan? Or can you prevent that by being around people that are going to help you from that happening? And now I pay attention to what I eat, yoga, meditate. Of course, we're instilling this in our players as well, but you have to do things. And the other big thing I would encourage you to do is get a hobby. So after all this happened, I went and got my pilot's license. I started with guitar, didn't work, got my pilot's license. Now, I'm into horses. So the horses are amazing animals. And it's just, and what really prompted all this, there's a place called Stillwater Farms down south of Lincoln. They take muscular dystrophy kids, paralyzed people, and they put them on these horses, and I've seen them change their lives. So I'm fascinated with horses and how to work with horses because I want to be a better coach. It's helping me be a better coach working. I could talk all day about horses, but have a hobby, something that when I'm riding those horses, when I'm flying a plane, I don't think about Nebraska volleyball. I'm just thinking about in that moment what I'm doing right there. So I encourage you all to get a hobby. And something else that's we really stress is with each other, for each other. You guys are all going to be working with teams. So if you can make it where everybody's working with each other, for each other, and I'm trying to get a volleyball team to do that. And I'm going to show you an example here. This is our 2017 team. The beginning of the year, we didn't look like this. Watch how they interact and communicate with each other after a point. They wouldn't come together, they were apart. And we lost back-to-back matches, and I thought the world was coming to an end, the season was going to be done, we weren't going to make the NCAA tournament. We had this talk, we worked through some things, we started with each other, for each other, we're going to commit to that the rest of the year. Not only did we go on to win the national championship, we went on and won 32 straight matches over 2 years. Just put up This team had no business winning a national championship, but they really embraced us with each other, for each other. And anyway, get your teams to be with each other, for each other. We actually got the patent on that state of Nebraska, so we can continue to use it with our teams, put it on shirts, and any other place we want to use it. And again, this is how I communicate with them to show them this is what a team looks like that's playing with each other, for each other. All right, another big thing in your world is trust. So I told you I got my pilot's license. Runways are built for planes to take off into the wind and land into the wind. In Nebraska, most runways are going north-south because the wind blows north or south. But when we get a storm, the wind's going to blow across the runway. So when I was going through my pilot training, and I'm sure you talked about you sweating, the first thing I did crosswind landings. We went out to Crete. It was in the winter, it was icy, the wind's blowing across the one runway. And this is what you have to do. You have to fly a plane sideways, and the last second you straighten it out. It took me 2 hours until I finally made my first landing. We flew back to Lincoln. I got out and said I quit. And my guy who was training me now flies for Southwest Airlines, but this is what you got to do. You got to fly sideways, and if you're on that plane, you're feeling that sideways, the wind's blowing. Otherwise, if you don't, you'll blow the plane right off the runway. So I got out of that plane, I said I quit. His name's Clay. He goes, John. He didn't, I know what he wanted to say was like, you're a big wuss, you know. But what he said was, you just have to trust your training. And that really changed my world in regards to coaching and how I communicated with our players. So our team and your team have to trust, you have to trust your coaches or your mentors. You gotta trust in your game plan, what it is. And when you're doing your thing, you gotta trust you're doing the right thing. And then you gotta trust in your training. And you guys are getting great training, but go back to that. And so when it's match point, and our players are back there serving, it's just them and the volleyball, they gotta trust their training. If they don't, they're gonna miss the serve because of the pressure and the expectations and how much is riding on it. So again, we can talk about that, but I'm gonna give you some examples of what really trust here is. And on our teams, we try to get it one step further, which is ultimate trust. And so I asked them, and because we got 6 people, 900 square feet, the ball's moving at 60 miles an hour, it's happening fast. They got to have ultimate trust. So I said, what is it to you guys? This is the first picture they brought in. This is the first test of a bulletproof vest. Okay? You say there's ultimate trust going on there? I would say there's ultimate trust. And you guys have that in your operating room. This is the second picture they brought in. This is a dog leading a blind dog. Okay, and so for our players, girls, they resonate more with this. We can play like the dog lovers, about half our team is dogs. But again, this is to them, this is what ultimate trust means, example of that. So can you get your nurses and people working with you that ultimate trust? If you do, it's incredibly powerful and it's awesome and everybody feels great. And ironically, the Chicago Bulls, if you watch the Last Dance documentary, they talk about ultimate trust. So again, I use this example here with the greatest coach, greatest team, talking about
the ultimate trust from Michael comes in the playoffs if you come through. I think he respected me because he knew I fought and I was competitive and I worked and I got the most out of myself. But I hadn't performed very well in the finals.
Oh, that's a good block there.
I was struggling and, I was so hard on myself. As a role player, I'd get, 5 shots a game. And so every shot took on way too much importance. Steve, be ready. He knew the camera was always on him. And I'm like oblivious.
He comes off, I'll be ready.
And then I'm like yelling back, like, I'll be ready. I'll be ready.
I know if they're gonna double team me, Steve's gonna be open.
It is Michael Jordan time. Did not have the shot.
Essentially, you guys are hitting that game-winning shot every time you pull that off when you're working with somebody. Right? So ultimate trust, very, very powerful. And the next thing we talk to our players about is what is their why. So I like that you guys are graduating today. What is your why to be an orthopedic surgeon? I told you in my next life, I'd love to be an orthopedic surgeon. You can see why, the experiences I've had and the people I've been able to meet and be around. I think it'd be awesome, but what is your why? What drives you every day? And I ask our players this, and I get, oh, my mom wants me to play. We get a scholarship. Oh, these stuff's really cool. But that's not going to get you championships, pro contracts, and those things. We got to dig down, but they have trouble finding what their whys are. So I'm going to give you an example. This is our 2008 team, and this is Jordan Larson right here. Jordan Larson just was MVP of the Olympics, won the gold medal for the USA team this past Olympics at 35 years old. She's from Hupper, Nebraska, one stop sign town. She told me in 8th grade, she was coming to Nebraska and win a national championship. This is her, and we did, and she did, but this is her senior year. This is a team, again, we had just graduated 4 All-Americans a year before. This team had no expectations. We're in the regional tournament in Seattle. Okay, the first night we beat Michigan and we're playing Washington in this match, who's #1 seed at Seattle, sold out. And here's what you got to know about her why. This is her senior year. Her mom, who started taking her to gyms at 2 years old, was going through breast cancer treatment. She had flown to Seattle. She saw the night before, was too sick to leave the hotel room to come see this match. We go down 0-2. I think it's over.
You know, at that point, as we say in Nebraska, the hay's in the barn. You've either done your work, and they know what they need to do, and there's not much you can do about it at that point.
Jordan Larson with an incredible kill up on the left side and received by Perry. Set up Carlson again. Nice up by Larson. He goes for the kill. Pancake by Perry, a scramble, and Washington sees it go out of bounds, and the Huskers are playing perfectly in the last 3 points. 4-0 run by the Huskers in this 5th set. That's Hagen from the back. Jordan Larson off the block. That's what she did so well in the 3rd and 4th sets, and we're seeing it here again in the 5th.
I mean, all we did was believe in each other and believe in what we could do. And we knew we could do this. I mean, it was in our hearts, and we just found a way. And this has been the story of this team this whole year.
Carlson again, this time blocked, and the defense for Nebraska getting it done in this 5th set. They are 3 points away from going to the semifinals. Washington back set for Carlson. Off of Sydney Andersen, kept alive by Tara Mueller. Nice heads-up play. Here's Washington now again on the attack. Carlson is a block by Jordan Larson.
And we're down 9-3. If you knew everything that we've been through since January, that it gives you know, just all those emotions are running through me, that these kids can find a way to pull that out. It's just I don't know, you know, as I said last week, it's all about heart and soul with this group, and the whole country just saw what I'm talking about.
One of the best that Nebraska has ever seen serving in the 5th set, and it's a service ace. And Nebraska has done it. They were down 2 sets to none. They put together 3 in a row to win this match.
So I really thought about what the hell just happened. It was one of the greatest performances I've ever seen, one of the greatest comebacks. We'd be like we were down 4 touchdowns with three minutes to go in the game in football. She willed it back, and I asked her what happened. She goes, "I'm not going to let my mom miss my last match." So her why was that powerful, that she was able to single-handedly. And I showed you those clips because she's making a play almost every play in that 5th game. We're down 9-3 coming back. So we're trying to get our people to tap into what their whys are. And if you get it, it's going to make you stronger and more powerful. All right. Last couple coaching secrets. There's 3 questions you got to ask yourself every day. Who needs me today? Somebody is going to need you every day when you get up. Can you figure out who that is? Find them and take care of it. I just know coaching my team, there's something every day. And Dr. Andersen mentioned this as well. There's something every day that's going to happen. Can you figure it out? Be proactive. Who needs you today? The second question is, would I be chosen again today to be in this job? Am I doing a good enough job that Nebraska wants to hire me back and be the volleyball coach at Nebraska? You got to ask yourself that every day. And the third question is, would I want to be coached by me today? And this is the one I fail the most at, because there's some days I know I leave practice and I'm like, God, I was a jerk today. These guys aren't going to want to play for me. And I go home and I'm just in the tank the whole night. But I want those players, when they leave practice, they can't wait to get back and have another practice and be coached by me. I got to do a good enough job that they feel that. And I want you guys to think about that, because you're working in very tense situations. It's, you know, with people that are helping you, and it's tense and there's a lot going on. But every day when they leave, you pump them up like that volleyball that's inflated, or do they leave deflated? And I got to ask myself that question every day. Do I pump our players up when they leave? Do they want to come back, or do they walk out of there deflated? That doesn't mean I'm easy on them or don't push them. It just means I got to do it in a way that inspires and motivates them to want to be better and come back. And again, Dr. Andersen did a great speech, and he talked about the feeling. Okay, I want to show you a quick glimpse of what the feeling that we're chasing, which is really a national championship point and all the little things that go on every day in practice and so on. So this is a video that I put together talking about the feeling, and if you can figure out the feeling that you're chasing every day, when you get done with your day or get done with the patient.
Swing outside, Kelsey Fane, off the block and up. They did it.
That's why we work so hard to get to this point. You can't buy that. You ain't getting that in school. I want our players to appreciate the tradition, the history of our program. All out where we train at the Maegen Center.
More. Kinsey bumps it over to Michaela Fecky. She did it! That's number 5. Nebraska wins its 5th national championship.
So I hope you're all have a feeling that you're chasing every day and you find that feeling. It makes it all worth it. Okay, I'm gonna give you, I'm a white coat today. I'm a doctor. I'm gonna give you a prescription. There's 3 bones you gotta develop. I'm trying to develop in all the youth in the state. The first bone is a backbone. Okay, we have to develop a strong backbone in our players and the kids in this state so they can stand up to challenges. They can be strong when they need to be. They can say no when they need to say no. And take that backbone into life. So we gotta develop a strong backbone. The second bone we need to develop is a wishbone, because we need to teach kids to dream big. And I know you guys are dreaming big, you wouldn't be here, but set big goals, go for it. We gotta, again, Jordan Larson told me in 8th grade, I'm gonna win a national championship and I'm gonna be an Olympian from Hooper, Nebraska. So, funny bone, I'm sorry, wishbone, dream big. And then the last bone is a funny bone, because what we're doing, we should have passion, we should enjoy it. It should be fun. We should look forward to coming to work and working on our skill every day. So those are the 3 bones we got to develop in these kids. So there's your prescription. Make sure that's happening. Okay. All right. Again, Dr. Garvin, thank you for having me here. This is one of the greatest honors of my life. Thank you very much and congratulations. Questions? John. Enjoy it. Great. You win once. My bosses right now. It's Trev Alberts. He hates Creighton. You know, we lose to Creighton, we'll be fired. That's Matt.
Coach Matt Town, the sports person here. I was just wondering if you could talk about failure just real briefly. One of the things as a parent and a surgeon that we want to kind of inspire is resilience. Just maybe your personal view and how you inspire your kids as far as responding to failure.
So it's a really good question. We now have 4 sports psychologists at the athletic department because kids today can't handle failure. Their expectations are set so high. And the players we're recruiting and a lot of the athletes that come to Nebraska have not experienced much failure. They've been the best at everything. Then they get here in the Big Ten. I mean, it's a tough conference. And so they start experiencing failure. So what we try to instill in our players is, one, have a growth mindset. Okay, you're going to fail in here every day. We're going to make it really hard on you and you're going to fail. But do you have a growth mindset to work through that and get better from that? We're not going to win every match. So get over it. But, you know, I've got a kid, Lindsay Krause, went to Omaha Scott. She won 4 straight state championships. They lost like 1 or 2 matches. Kelly Hunter, who I just hired was at Papillion High School. They went 3 years without losing a match, #1 in the nation, 2 years in a row. So they get here and we get our butts kicked and they're like, what, you know, they think the world's coming to an end. So we have to work really hard at that. It's a big problem. You know, and I think if you looked probably Dr. Garvin, Andersen, myself, I mean, we probably failed a lot growing up. And, but these kids are protected today and, you know, so I'm not sure that's answering your question, but it's a big issue. And we kind of need to wait. We need to let kids fail as they're growing up to fix this. I do see a change coming in this new generation we're recruiting. I'm really excited about our group of kids now and the kids coming in the next 2 years. For a while there, it was really hard coaching. And I just saw so many kids struggle. But now you throw in, you know, the other part of this is the social media part. You know, they're all perfect on social media. And now if the more perfect they are, they're getting money to get paid for it with NIL deals. So they live in this false world that isn't reality. And so we're working really hard on that. And again, these are all the things I talk about with each other, for each other. What is your why? You know, do you have it? You surround yourself a team within a team. We're trying to instill those things in them. Instead of like, what do I look, how many followers do I have on Instagram? You know, and how pretty do I look in this picture? And if you follow these athletes, and our team is the most followed social media team in the country in women's sports. And if you follow these guys, you'll just see some of the things that they do. I mean, it blows my mind. But this is the world they live in, and now they can make money doing it. And so it's a real challenge. And then you throw in the failure part, they struggle with it, and we got to work them through that.
Can you speak, how do you get buy-in from players? Because they're all super talented and some of them aren't going to see the court probably like they hope to.
Yeah.
So how do you keep those kids engaged to not say, I'm going to go someplace?
Yeah, it's we try to get them to buy into our culture. At some point, you're going to have an opportunity. Every day you get to compete in here, and if you're the best, you're going to play. And then we outline, okay, you say, well, what do I have to do to play? Great, here's what you got to do to play. So it takes a lot of work. It's a lot of building relationships with them, that they have that trust and they believe in what we're doing. And we've had players that have been All-Americans, and we've had players that have gone through our program that have loved every minute of it. In fact, I'll just give you one example. Maggie Griffin grew up in Lake St. Charles, outside Chicago, very wealthy family, played in a great club, was all everything, comes to Nebraska, doesn't play, role player her whole career. She gives her senior speech, gets offered 3 financial corporations on the mile drive in Chicago, goes to work for, I don't know, Smith Barney or one of those as a financial analyst thing. 3 months later, she calls me. She goes, Coach, I miss it. Can I come back and be a volunteer? I go, great, come on back. She now has started a volleyball club in Lincoln. She has a 12-court facility, and she's ready to build another facility. So there's an example I'm giving you. She didn't get all the awards and all that, but she got the experience, and she wants to stay with volleyball. That's one of our very proud success stories that I can share with you. And if they're not happy now, it takes them 30 seconds. They click in the portal and they can transfer. So I tell my coaches, every day is recruiting. We have to recruit our current team. We've got to recruit our future team. Every day, we got to recruit everybody. So it never stops. And I really believe that now. We can't assume somebody's happy and we got to build those relationships, coach them and give them what they need. So it takes more work, but I got two really talented young assistants that have got the energy to do it. And I've had to work a lot harder at those relationship parts as well. I mean, even we got a little walk on from Norris. I mean, if she made me a cake for my birthday, I make that kid feel like an all-star every day. She's never going to be an All-American, but I make her feel very, very valued part of our team and a very important part. Any other questions?
Don't be shy. I'm sure there's some questions out there.
Questions?
You recognize one of your players here?
Oh, Anna, when'd you walk in? Oh, okay. I was gonna call you because I want you to talk to our team. Later. Well, here's one of my former players that her career went good, bad, and she's now a doctor. So, and your daughter's playing volleyball, right? Yeah.
Coach, when you're playing at the highest level and a lot of your teams perform their best in the most stressful situations, is that something you can teach, or is that something that's just innate to the player?
We train it every day. So we put them in situations that they don't think they can get out of. We put them in pressure situations that they have to work through. Right now, they're with my strength coach. I'll give you an example. So do you know what a gasser is? Okay, so it's up and back twice. They got to do it under a certain time, and they repeat it. You go into your max VO2 system, you feel it. We take a box. Anna's done this. You remember? You remember this? We take a box, we put 12 items in it. Okay? Guys, you get 30 seconds to look at the items, memorize them. Now we're start doing gassers. And then we come back and we pick one person. They got to name all 12 things. So again, we're working on, I'm not worried about how this gasser is going to make me feel. I got to remember this right here. So we call that staying in the moment. Okay? You got to be in the moment, focus on the next point, and not worry about everything else. And then we have a sports psychologist that helps train that too, the mindfulness part. They have big words for it. I just say, hey, it's the next point, stay in the moment. Yeah.
The people who are leaving here are going from one environment into a new environment. And in my career, everything has been about teamwork. So what kind of advice can you give to the people who are leaving, to go off and do their fellowships and whatever, and how to blend into it and make a team really work?
Yeah, what I would, so we have new players coming in every summer, and this is what we talk about with our team. We call it BDR, build deeper relationships. So you gotta connect with them right away. And so for our players, the mill is one of our best recruiting. You guys been, when the mill is? It's one of our best recruiting deals. They meet there for coffee, and these guys drink coffee like in the afternoon. They'll go there and meet in the afternoon, but they're meeting and talking and socializing. And remember, kids today, they don't socialize. They're on their phones. They don't sit down and talk. So that's one thing, is build relationships and take the time to do it. It'll pay off. It's a great investment. And then two, prove that you're a team player, and we have another saying, it's called we over me. Is it about you or is it about the team? And I'll give you an example of that. Let's say Anna has a great night, gets a bunch of kills, gets written up in the paper. I'm going to read that article. If she said, I did this, and I did this, her butt's in my office. I've got all the I's circled. I go, is this about you or is it about your team? And so we talk about and preach that we over me. It's about Nebraska volleyball. And you gotta buy into the team. So if these guys are going to new places, Jace is going to San Diego. Hey, I'm all about the sports institute or this surgery center, whatever they call it out there. I'm all about this. I'm gonna make this place great. I'm gonna help, and just investing in that teamwork part of it and the people you work with. But it takes time, it takes energy, and sometimes I just got to do my thing, and that's the other big thing. But in the sport of volleyball, if I don't make a good pass and we have a good setter, Anna can't get kills. I don't care how good she is. So it's a real teamwork game, and that's why we got the patent on with each other for each other. This is how we roll here. And again, it's building a culture. And if you go somewhere where there is no culture, maybe be the first one to start building it.
Okay, fantastic. Okay.